I know,
Everyone
it's
online,
tricky.
just confirm it's okay.
Wonderful. He's
Hi.
How are you?
Andrew.
Hi, Joshua Chick.
To meet you.
I haven't heard of you.
Comptroller, with that, correct?
So,
Yes.
I'm on the-
Come off mute.
Okay, yes, yeah.
Yeah, I don't know if it's congratulations, but they're teenagers.
Okay.
No, we don't.
One second.
How are you?
I was kind of buried in the shell, but yeah.
We're all buried, and that's the consent also buried. There. Actually, well, they're thriving, but it's.
Good. Yeah, yeah.
I just wanted.
I understand. For my nieces and nephews.
Want me to write a note?
Yeah, that would be.
Because.
Good morning, how are you? Data?
Yes, we can hear you.
Hi, can you guys hear us in the room?
I can hear you, Ben, but I'm not in the room either, so I think we might have lost connection with them.
Thanks, Hannah.
hear you most likely.
All right,
And then we can do,
Yeah, for now and then hopefully.
and we're still
Yes.
working on getting that
we're
going.
gonna work on,
Okay,
and we're gonna need that for the discussion, but for this first section, it's just Angie.
all right,
So.
Right, double pause.
So be able to,
all right. So can folks hear me now?
let's see.
Are we muted? or not?
We can hear you.
No, we are not.
Can
Okay.
everyone hear us?
Yes.
Yes.
Yeah,
Yes, we can hear you.
And we're
That's
gonna,
what I wrote on.
Hannah, could you say that again?
Yes.
Terrific, thank you.
Great,
All right,
thanks so much.
all right, thank you.
Okay, and then to move the slides, we're gonna use this arrow.
Okay,
Are we-
okay.
You feel good about that?
Yeah, I think I'm okay. We're gonna give it a try. Yeah, all right, yes, please don't go quiet. Thank you. All right. Thanks, Olivia. All right, everybody, we're gonna try this again.
I just got it, we can hear you now.
All right. All right, good morning, everyone. We are going to get started. I apologize for our technical difficulties. We've been really struggling in the building for more than a week or so, but we have complete confidence in our BITS team, which is our IT team here at the state, that they will get it resolved for us. In the meantime, thank you, Olivia, for lending your laptop to us while we work on getting the rest of this resolved. So pivoting is always important. For those of you who don't know me, I'm Andrea Barton Reeves. I am the Commissioner of the Department of Social Services, and I really do appreciate your virtual and in-person presence at this meeting today. It is in many ways a culmination of a lot of the work that we have been doing together. I will first admit that much of that work has been a little bumpy and imperfect, but whenever we pivot to anything new, that's a part of the process. So I appreciate your patience and your concern and the ways in which you have reached out to redirect the work that we have done. But in the end, we are really doing incredibly important work for people who need us the most. We know that there are thousands, if not millions of people that are going without the care and the quality of care that they need. And any effort that we make to improve that process is an effort in the right direction. So I appreciate you being here. There are a couple of things that I wanted to mention. A few people, one person in particular mentioned that you did not get the materials in time, and I do want to apologize for that. So we will make every single effort to make sure that you do have them more than 48 hours in advance, well ahead, because we're asking you to take an extraordinarily heavy lift. And that means that we have to be ahead of that to make sure that you have enough time to be prepared to engage meaningfully in that. And we appreciate that feedback, and that will absolutely change. You should have either the slides or some other kinds of materials today. If you're in the room, we have an abbreviated version of the slides. I didn't think you needed to see, every single thing I was going to say. So there is a pile that's on the table in the room, on the table with the food. There is a little bit of food. For those of you who are not in the room, I'm sorry, I could not feed you virtually, but we are here. So if you need a hard copy, those are available. I'm really hoping that we'll be able to do some pretty significant things today. Today, we are really looking at the culmination of the work that we've done. So you will see in many of the slides, lots of the suggestions that you've made over time, some of the models that we've seen from other states. Please understand that this is a starting off point. It is in some ways a combination, and in some ways a way for us to collectively build a roadmap to the next place that we will go. So if what we present today, what we talk about today, you say, you know what, as we're having these discussions, I'm not really sure this is working. Maybe we should consider something else. This is the place and the time for us to have that discussion as we move forward. So I want to make sure everyone knows that we are working together toward a result that might not be a perfect result, but it will be the best result we can come together that we can reach as a collective. The one thing I actually would like to do this morning that is not part of my opening remarks is I would like to have a moment of silence or acknowledgement for the at least 16 people who have lost their lives in Maine. We all do the work that we do because we believe in people and we know that lives are precious. So if I could just ask just for maybe 10 seconds or so to acknowledge that loss, and then we will move into our work. Thank you. All right, so let me just talk a little bit. I'm not sure if you can see the slides advancing where you are, but I have them here. So our primary care program goal really is to improve the biopsychosocial health and well-being of our Husky members, especially those that are historically disadvantaged members, and we know that. So we really want to reduce inequities and racial disparities. And our committee as a collective is charged with doing this work. So we really, as I said before, we really do appreciate your engagement in this and your program design. If you have anything that is revelatory or revolutionary, now would be the time to share it, because this is why we're all here together today, okay? What we hope to do when we leave this meeting today is to get your feedback and your input on some key delivery decisions. What are some of the key things that we think primary care should be doing differently or better to improve the health and well-being of our Husky members? And what role should primary care play in addressing those health-related social needs? And should our approach to defining what primary care practice means be prescriptive, flexible, some combination of that, something else? But we're really now looking for some guardrails. And at the end of the meeting, we're hoping that you'll be able to have a list of the top things that we want to do as a group in primary care, your preference on the spectrum of options that might be available, and your feedback on the spectrum of options around the level of prescription versus flexibility or some other option when it comes to care delivery. And we'll have examples of what that means in particular as we go through the program today. So we identified what we think are some of the opportunities that are ahead. If there are more that you'd like to share, please do so. This is supposed to be a very interactive process. Well, obviously, there is an opportunity with primary care payer reform to address the disparities that we all know exist in the quality of care and member outcomes. And we've seen these disparities writ large during COVID in particular. We want to ensure that members have easy and timely access to care and addressing the ranges of barriers that exist that now stand in the way of that being a reality for many. We've heard very clearly and want to continue to acknowledge the role that the social determinants of health or health-related social needs have in this role in identifying and changing primary care, and to better identify what those
I think we lost you.
You're back, but you're muted, Commissioner.
All right. All right, are you good?
Yep.
All right, perfect, thank you.
But we've lost your slides, I think, but we can't hear you now.
Okay, well,
They're online. Let me see if I can just quickly reshare. The slides got lost on this, but it's okay. I think we just need to reshare.
okay, thank you, Lily. She's so-
There you go.
Okay, all right,
Thank you. We're good now.
thank you. Yes, it absolutely takes a village. So this is indicative of why it takes more than one person to do the work that we're getting ready to do. All right.
Collaborative care.
That's right, that's right. So I think, let me just go back to, I think 4, when things kind of went sideways technologically. So, so we want to enhance care coordination and team-based care. These are some of the things that we've heard. Among the many, many opportunities that we've spoken about as a committee, we want to improve chronic conditions management, really with a focus on really reducing unnecessary inpatient and ED visits. And finally, and this does not mean that this list is exhaustive, these are just the ones that have bubbled up over the time that we've been doing our work together, is to invest more in primary care as a percentage of the total spend, right? As an opportunity to increase preventive care and prevent, long-term hospitalizations and other kinds of outcomes. Okay. So with that, I am turning it to our Medicaid director, Guy Woolston, who will walk you through some of the other slides today and facilitate our discussion. Okay, great. Sure.
Need to access online. Is there a way to, is there a user password that you use to get up here?
You're gonna have to speak into the mic.
Yeah.
Here's the question.
This is Mark, this is just a tech question about the,
User password.
Sorry.
About getting a guest password. Let me check on that. Is there not one? You don't think, did we ask?
I'll use the hotspot.
Okay, all right. We'll
Double check with Michael.
I think there's more staff upstairs, so let me just check on that.
and Mark and others, I really appreciate the comment. I will commit one way or another to making sure that when there's a substantive question on the content that we communicate it, even if it's repeating, if there's a question just about like the food or the bathroom or stuff like that, we won't do that. So just know that one way or another, you will hear. Great. So I think I've met everyone in the group, but just in case not, I'm Guy Woolston. I'm the Medicaid director. I know that your time is precious, and I want to get as quickly as possible to the discussion. Going back to the goals for today, leaving with those top things that we want to change and a perspective on social determinants of health and on flexibility versus prescriptive. If you'll indulge me though, I think it's important to spend just about 5 minutes just recentering on some of the challenges with the status quo. And I want to do that because I think before we think about where we want to go, it's important to understand what is broken or needs fixing today. So as the commissioner mentioned, we have 6 priorities, 6 opportunities, and these very much reflect what we have heard from you and the extensive member feedback, the member advisory groups that we've done, and the provider outreach that we've done over the last year. Hopefully none of these is a surprise. I'm going to spend about 30 seconds on each of them, but I do want to recenter on what's broken or might need improvement. So the first is on disparities. And this is a graph. Here we're taking 40 commonly used quality measures. And for each quality measure, we identify the racial or ethnic group with the worst outcome. And we just count it up. And you can see that Black African Americans had the worst quality outcome for 30% of the quality measures. And Native American Pacific Islanders, non-Hispanic members for 28%. That is to say, there are multiple ways of cutting the data, but that's just a way of saying that along these 40 quality measures and many others as well, we see quite substantial disparities along racial and ethnic groups. And these are mirrored in national data as well. I'm not telling you anything you don't know, but I think it's worth recentering on the problem with the status quo. And I think you can see that really clearly with this graph here. The second opportunity, and this is actually, I think, a strength in Connecticut's model in general. And one of the things I think we want to be sure not to disrupt is it's both a strength and an opportunity, is on access to care. So on the left-hand side, there's some statistics. I won't go through it. I think you've seen this slide before, showing that we do in general have pretty good access to primary care in the Husky program. There are absolutely opportunities, access to transportation, extended hours, workforce diversity, and others on the right-hand side. But I want to bring up both the the kind of the good and the opportunities, because as we're thinking about what needs to change, I believe, and I think I speak for the commissioner and the department here, that we want to build on the access that we have today and not disrupt it. And I think we want to just keep that very much in mind. The third opportunity is on social determinants of health. There's some data on the slide. I guess the takeaway is Medicaid members on average face challenges to healthy living that are both clinical and social. And those social determinants of health are associated with, and there's pretty good research to show that they cause bad health outcomes like hospitalizations and emergency department visits. And there are a couple of quotes on the right-hand side from providers on how social determinants of health interact with the clinical challenges of our members. And one of the things that we've heard from you loudly and clearly over the last several months is that having a primary care model that integrates or incorporates social determinants of health one way or another is important to the challenges that our members face. And so that's why we're going to devote a whole section of today's meeting to social determinants of health. The fourth is on care coordination and team-based care. This opportunity comes from our July session, where we heard from you that there was real interest and a real opportunity to build capacity for collaborative care like community health workers, community-based organizations, and to integrate with existing care teams. And we heard you, and that's why this is on our list of the 6 opportunities. Opportunity number 5 is on chronic disease management. As you know, Husky members face, on average, high burdens of chronic disease. Some of the most common ones are behavioral health, hypertension, asthma, and diabetes. These are big drivers both of bad health outcomes and of spending, including hospitalization. And there's a strong correlation. Our members who have chronic diseases are much more likely to have ED visits and hospitalizations than those without. And there's good evidence that helping to manage chronic disease can help. And we want a primary care system that empowers primary care clinicians and their teams to help manage those chronic conditions. So I think that's a real opportunity as well. And then last but not least, taking a big step back and taking the macro view, the 6th opportunity is an opportunity to consider investing more in primary care. And there are a couple of different ways to back into this. One way is to look at the Office of Health Strategy's target for primary care spending. And we in Medicaid and Husky are below that target. We also, depending on how you cut the data, we're a bit lower than many peer states in what percent of our budget we spend on primary care. Now, I wouldn't be a good Medicaid director if I didn't say that merely spending more is not the goal, right? The goal is to spend more to get better outcomes for our members, to improve the disparities, to help prevent downstream utilization. So please don't interpret this slide as just merely funneling more money. It's the recognition that there may be an opportunity to spend more to get more, or to spend more and prevent more. And I think, given the comparisons to other states and the OHS benchmark, I think there's a real opportunity there. So, yes, Commissioner.
May I just ask if you can stop here and ask if we have, based on all of the meetings, have we identified the right 6 opportunities?
Great, and Commissioner, I'm just going to repeat the question back to the microphone so folks can can hear it. No, it's good. I'll have to play MC a little bit. So the question was, we have these 6 opportunities. These have come from the meetings with you all, with the stakeholdering that we did before the kickoff from our quantitative surveys. Are we missing anything big? Because before we get to solutions, I think it's really important to make sure that we've identified the right opportunities. So please, folks online, just hop in. Folks in the room, I would love to hear from you as well. Yeah, Mark, go for it.
I think that it seems like a strong list on number 5. I would make a pitch for including
So for folks online, Mark Schaefer said on number 5 on the chronic conditions management, focus both on the management and on the prevention, which I think is a good call.
and maybe this is a question for the providers in the room, is there kind of administering, should there be a goal to make it easier for you to work with Medicaid?
Great. So Paul's question was, should there be a goal to make it easier for providers to meet with Medicaid? By the way, I'm sorry that I'm playing this translator role. I hope you'll forgive me. It's kind of awkward, but.
I think that no provider would ever say that they would not want to see a lower administrative burden in dealing with any type of insurance payer account. That is a chronic issue, and any resource that we're using to manage administrative burden is a resource that's coming to provide correct patient care. So I think providers will welcome that. I think there's a lot of impact about how we go about doing that and what that would mean.
Yep. I'm going to call on Alice online. I see your hand up, Alice, from Clifford Beers.
Hi, everyone. I'm sorry. I'm on trying to balance a lot of stuff. I don't see the word at all on there around behavioral health. And, that is something that came up, pretty high in your in the data. And, I wouldn't mind you linking it to social determinants of health, because often it is the chronic stress that related to those social needs are then, needed behavioral health. But just making sure it's in this opportunity list. Thank you.
Alice, that's a good call out. You're right. The word isn't there. It was very much in our mind with the social determinants of health, the chronic condition management, and the care coordination. But I think it's a good call out that given that it's one of the top challenges of Husky members, I think it's a good call out. Something we can add. Good. Smart. Yep.
Do my best.
Thank you.
Pass around my
Yep.
laptop.
Go for it.
Hi, so I have concern about underlying definition terms access. When we talk about opportunities for improvement, if you look at page 7, slide 7, sorry, it talks about 93% of patients being within 15 miles of PCPs. Access does not equal proximity. If folks aren't accepting, patients with Medicaid, that's not access.
Yep.
So just as long as we're understanding what access means, number 2 is critically important. But based on that slide, I'm not sure if we're on the same page.
Appreciate that. Let me, I'm just pulling up that slide again. Let me ask you, do you think we've captured, could you come back? Yeah. Do you think we've captured on the right-hand side? So we tried to have this both the opportunity, that what kind of is good, and also some of the opportunities. Do you think on the right-hand side of that slide, we're capturing the key challenges?
Again, provider access in those areas, physical health, behavioral health, dental health. We got a lot of
Listening to the primary care.
people with Medicaid.
Mm-hmm.
What do you mean by access?
Mm-hmm.
Being, a mile away from somebody that's not accepting
Mm-hmm.
insurance doesn't help that person.
Mm-hmm. Mm-hmm. It's helpful. Maybe I'd love to get a little bit more specific on what other opportunities you think we should be including, either now or offline. But I definitely hear you that de jure access is not the same thing as de facto access, right? That makes sense.
May or may not need
to go on the list, but overall, we just need to make sure that you also improve your data collection so that we're actually appropriately monitoring improvements or not. And particularly data by race, ethnicity, and language.
Yeah, I mean, it's part of that, is
Well-
that like an enabling capability, you know, I think in order to achieve some of these areas for opportunity, a lot of it is going to be starting to consistently collect, you know, some of those key data elements that don't exist. They don't exist in claims data. Providers' offices are going to have to collect and share that information to be able to do the kinds of, you know, slices and dices to get under the hood of where we need to target. You know, these are very broad areas of opportunity, but a lot of it is kind of then figuring out the targeted areas for intervention.
And could I
Carol
say-
had her hand up.
Oh, great. Yeah, go for it.
Yeah, I have two questions. Actually. Does this include individuals who are elderly as well? And if it does include individuals who are elderly, is it also true that it's harder for elderly to get care, and why?
Good question. Brad, do you want to take that?
The data, in terms of broad data, is basically across the spectrum for DSS. So it includes children, adults, and older adults as well. So it's not necessarily, they're not necessarily cutting across in terms of looking for each of these opportunities. These are broad swaths. And I think, you know, we've discussed there are different needs within different communities. So I think, Carol, your point is appropriate to call out that like subpopulations will need different things. And it's important to keep that in mind.
But I know Angela had her hand up.
Angela, and
before,
then maybe Mark.
And then Mark.
So for an area for improvement.
Yep.
I think when the access, the Affordable Care Act, you know, was initiated, there was the 10 essential benefits. Like everybody had to deal with the 10 essential benefits. Everybody was working from the same baseline. If the state could produce the medical history document that would capture the data that we're looking for and have it standard across anyone who is accepting Medicaid, I think that would help to get to the heart. Every time you go, oh, every year we have to update the data every day. Well, every year you have the opportunity to tweak that form to get the information that we need, but we already know patients are, you know, have to opt into that process.
Mhm.
So that's a key time to do it on an office visit or online when you're enrolling. Some of that information can be requested on an opt-in basis so that that technology piece can happen, data collection can happen. But I think DSS should be driving that initiative to have all providers come into compliance so we get what we need to track the improvement.
Great. I'd love to follow up with you offline on that, Angela, if you're willing.
Mark.
I just, thanks, Brad. Wanted to follow up on two of the comments that were made. One was about older adults, which is maybe put another way, are all the Husky programs contemplated to be included, and as it pertains to dual eligibles in particular, the 70,000 or so who are either older than 65 or have a disability of some sort. It would be useful to understand whether that really fits within the rubric that we're solving for, because it does certainly have implications for what you might focus on building out in terms of practice capabilities. I'm not looking for an answer now, but just to sort of raise that specifically, are duals part of the model? And I know that it has savings implications because of what Medicare contributes to the cost of care. The other was if I can pose a question to Alice, because I'd like to do more than just say we want to see the words behavioral health in there. I'd like to, because the behavioral health conditions, both psychiatric and substance use, were an order of magnitude above the others. In our own data, we saw behavioral health conditions of 50% comorbidity with the chronic conditions. So to your point, Guy, it's part of chronic condition management potentially, but there are acute conditions that are behavioral health. There are chronic conditions that are behavioral health. There are things you can build into primary care like bupropion management, which is probably under accessed today in primary care. There's pain management approaches that can be used to reduce the likelihood of developing substance use conditions. So, so I'm really interested in what other folks think about in your list. I don't know if we can go to the list again.
Yeah.
Oh, sure, yeah.
Whether you can just challenge the group or Alice maybe to start to define, not just to sort of add the word, but what is it we think this initiative could or should do around this big area of behavioral health? Recognize that primary care provides most behavioral health just on a quantity, quantity basis, but also that it depends so much on the rest of the services.
Great. So Alice, I would love you to weigh in just one quick thing before you do on Mark's first question on the our members who are duly eligible for Medicare and Medicaid. That is a policy. God, could you go on you?
Yeah, sorry. It's just
Managing the calls. That is an open policy question. And as you know, as well as anyone, dual eligibles are a very important part of the Medicaid program. There's complexity when someone is dually eligible for Medicare and Medicaid with the savings that you were mentioning. And so that I think when we, in our future session, when we're thinking about the payment model, I think that would be a time where we'd really want to think, okay, here's the direction that we're going. Will that work for our dual eligibles, or do we need a whole separate track for them? Alice, I didn't mean to cut you off. If you want to hop into Mark's comment, I'd love to get your perspective. If you're still online. Or anyone else who wants to weigh in.
I was just going to say, I think this will lead to the next conversation or kind of the discussion questions, like what's the priority for this group from folks, and kind of hearing from all of you, like what are the most important domains for us to focus on as part of this work? And that will get into, I think, the next part, which it does include behavioral health integration as one of those. And I think in data as well as a part of it. So I do think it might lead nicely to that. And I know Joe, and then I think Angela, that's okay. And then maybe after that, we'll move on just to the next. So be right back to you.
I dialed in, so I'll see my phone.
Oh, okay. I'll stay over here.
I'm sorry, did we give Alice a chance to respond to Mark's comments? I know she only said everything.
And we can come back to Alice. Will be more, I think, more opportunity for behavioral health. Go ahead, Angela.
This concern, as a follow-up to the dual eligible issue, can you all give us some type of magnitude of that population? It's really easy to say, oh, we're going to set that aside. We're not going to address that right now. What's the magnitude of that set aside?
Yeah, it's a good question. I have that number in my inbox. Let me during the break, let me pull it up and bring it so I get it right, both in terms of the number of people and the spending. I'll circle back on this. I like the question. Always starting with the data. So thank you for that.
And I think we can answer it, like you said, pretty quickly.
Yeah.
Just want to briefly go back to the access issue. Give some context to that issue. And I think it's important to think about this in the general context of the entire care spectrum, but we live in access, I'll say, a mobility crisis in general, across the entire state. And it's not just for Husky, but the Medicaid that's across the board. And there are a number of primary causes to that, but the solution to access really needs to go beyond just one single payer, one single program. We have seen declining ability to recruit providers and clinicians in the state of Connecticut. We have an aging provider population, particularly the aging population, aging beyond what would be the comfortable norm that we have. And the majority of organizations are stretched to the limit on access across their entire population. And so when we think about how we solve the access issue, for this conversation, we can talk about how we do that for this patient population, but I think we understand the large and the broader implications of that. As we think whatever access issue of this primary care behavioral health specialist, they all have slightly different issues and causes, but we're dealing with a much larger issue than just the population process. And behavioral health in particular, I just want to point out the primary driver is that the majority of providers do not participate in any insurance plan for behavioral health across the state. And this is a huge issue that we have more than enough behavioral health providers, but the number that participate in insurance plan is much smaller than the minority that we have.
Thanks.
Just a quick process point. So I totally agree. And there are challenges and opportunities in Husky, and then there are challenges and opportunities writ large. I pulled up the slide just to say explicitly, we're gonna have to draw some boundaries around our discussion. Otherwise, we won't really make progress. So what we're gonna do and what we have been doing is for ideas that this group has that are good, but are beyond the scope of Medicaid primary care reform, we're capturing them and we're going to continue to capture them here today. And we'll have to think about the right forum for them. So I totally agree with your comment. I just wanted to say process-wise, that's how we want to handle those suggestions. First of all, thank you. This is really, I'm just going to go back to that list of opportunities because I agree with the commissioner. We need to make sure that we're aligned on the opportunities and the challenges before we get to solutions. Any other comments on this? Yeah, Commissioner.
Thank you very much for what I'd like to say is that I'm sorry.
Actually, it's Guy and us.
Oh, the great ideas. Okay.
Yes, so this one is meant to capture the communities, but they're also so what I really want to make sure is to understand that this is it's not a singular process. It's not a one and done, that we're really going to try to get to those issues that will allow us to make the most amount of progress in our first phase and then return to these or try to implement some portion of these as we continue to iterate this model, because it is going to take a long time to reform primary care. We are not going to do it on the first go. Okay, so thank you.
All right.
So I appreciate that, Commissioner, and I think to that point, though, that also helps us determine and drive what our measures of success are and how that potentially needs to be phased. So that we're not losing sight of the ultimate goal, but that we are establishing what the different phases of success metrics for these initiatives should be.
Yeah. And so to that point, you can, and I think we'll see that happen as we walk through. I'm sorry, Brad.
Oh, you're fine. Sorry.
So let me just say, all right, let me just say that when we take a break, so you saw me walk out of the room because I called the CIO, like you need to come fix this. Okay. But we'll do it at a break because I don't want to lose the momentum that we're working on. So if you see me walking in and out, that's what I'm doing is calling in the big guns to get this done. Okay, so but to your point, I think we can, as we walk through this process today, really begin to identify what are the first things that we think we really want to tackle in this first phase. Right. So if we think that proximity versus access is something we want to tackle, if we can decide whatever that is. I'm not going to name them to be prescriptive at all. So we can talk about that. And then let's implement, then let's work on that model and let's implement that. Then let's come back and see, did that work? Is there something else that we should be doing? You know, should we move something else or swap it out or add something so that we can continue? Now, the time frame around that is really going to depend on what we decide as a team, right? What we decide as a group collectively in the room, online, lots of other stakeholders that will be a part of the process. But so Tiffany, to your point, that's exactly what we're envisioning. I'm sorry, I haven't been really clear in articulating that, but that's the idea, is that they don't go away. But I think today is the day we're going to decide, okay, what's going to happen at least what's phase one looking like? Okay, thank you.
Thank you.
And I want to just look at Ben. I haven't been able to see all the comments. And thank you for that point on the microphone being circulated. We're working on it. I did see a couple of comments just lifting up Tiffany's comment saying it was a good point. So for those who aren't reading the comments, I just wanted to acknowledge those. Okay, other comments on the opportunities. Okay, I'm gonna hand it over, and I think Brad's gonna talk through the kind of where we're going, and then we'll take it from there.
Sounds good. And I think Olivia's taking over for moving around the microphone on our laptop for now. So hopefully everyone can hear us. And so today, and I think just as the commissioner said, and actually some of the questions like, where do we start? Because there's a lot of things where we could focus our attention. And we're kind of answering some of these questions today, and it's really on the care delivery redesign. These are kind of the essential questions as we're framing them on care delivery, performance measurement, payment model, and then thinking about a cross-cutting equity strategy and how do we reduce those inequities and racial disparities. So today, the focus is on what are the key things that primary care should be doing differently or better to improve member health and well-being. And just as a reminder, we talked about this on last meeting, is where are we in this process? So we've had, again, we're in the middle, we're in kind of the beginning of programmatic design, but we did do a fair amount of background discussion, context setting, and there are a lot of opportunities as we're kind of framing them, things that we think could be doing better. And so on program design, the things that where we're starting again is on care delivery. So what are the care delivery requirements, performance, payment, equity, and then subsequently, we're going to have to come back because things we talk about today may not fit with conversations we have in a few meetings, and we're going to have to figure out how do these things fit together, what is something that makes sense in terms of a model, and so these things will need to come back up. And then subsequently after phase 2, again, this initial programmatic larger picture is more detailed programmatic design and implementation, which will take a much more time and effort to get into many of those specific technical specifications that we'll have to get through. So as a reminder, what are we hoping to leave today's meeting with? And so it's these 3 key things, a top list of things, and we've already started talking about them, that we want primary care to be doing differently or better to improve member health and well-being. The committee's preference on a spectrum of options around the role primary care will play in addressing health-related social needs, and the committee's preference on a spectrum of options around the level of prescription versus flexibility in terms of care delivery. And as I already mentioned, there's capturing other ideas. I'll just say like some of these things are things that may not fit within this conversation, but we are listening, we are interested, we realize there is a need to address lots of components of care, including more broadly outside addressing health-related social needs, even outside of what we're going to be able to accomplish through primary care, realizing primary care is not the only solution. And so we're going to jump into kind of the first topic, and the first thing we're going to do is review the primary care capabilities and some illustrative examples, just to give you some framework. We're going to ask you to actually do a survey if you haven't already done it, just to help start the conversation, and then we're going to have a conversation about it. We're going to try to keep time. I know, apologies for some technical issues, and thank you, Commissioner, for helping with this. We will still try to keep us on track as much as we can, and so we'll make just to make sure that we're moving through material, but hearing as many folks. And again, this is the preliminary conversation on program design, that these topics will need to come back up again. And
Brad, we're only 7 minutes behind the schedule, so.
Great, thank you. Appreciate it. And so these are the 2 questions we'll ask in terms of what are the key things that primary care should be doing differently or better to improve member health and well-being. So we do want to prioritize because there's many things that we could do. What are the priorities? And then which of these functions or capabilities is most important to addressing our equity goals? So these are the domains as we've laid them out, the honeycomb approach or appearance on this screen. And I'll just say them out loud. And then the next screen, and you may want to keep this handy for those in the room, we've printed this out so you do have it because we will come back to this and we're going to ask you again to rank these. And we'll go through some examples right after this slide. So it's 1, team-based care, 2, chronic condition and targeted care management, 3, cultural competency, 4, accessibility of care, 5, patient and caregiver engagement, 6, data infrastructure and data sharing, 7, acute care coordination follow-up, 8, behavioral health integration, 9, specialty care integration, and then 10, health-related social needs. Of note, given the interests that I think both DSS and this committee shares on that, we'll have the next topic will be dedicated to discussing health-related social needs. So just to provide some examples of team-based care and, of the key domains, so we'll start with team-based care, and that can look like, what are the practice team requirements? Is there integration potential of a community health worker and other other care coordination personnel? Chronic and targeted care management. So that can be self-managed support services for chronic diseases, empanelment. So people are empaneled in a primary care provider practice, and then risk stratifying patients and deliver targeted care management. So thinking about population health approaches to care. Cultural competency, this can be care as culturally and linguistically competent. So it might require maybe implicit bias training or other specific trains or specific functions like specific access to translation interpreter services. For accessibility of care, so making sure there's 24/7 care access, after hours or weekend sessions, same day urgent care capacity, the video telehealth capability. Patient and caregiver engagement. This can be patient and family caregiver advisory council. Some of you may be very familiar with these, and processes for patients and caregivers to advise on practice improvement. This can also be at the individual level where we're really focusing on making sure that individuals are engaged in their own care and are really helping drive that. Data infrastructure and data sharing, process for electronic exchange of information, referral management, use of electronic health record, or participation in a health information exchange, HIE. Connie is the one in Connecticut at this time. Acute care coordination and follow-up. So identifying unplanned hospital and ED visits and figuring out how to follow up and what that follow-up process is after hospital and ED. Specialty care integration. So specialist e-consults, time-limited co-management, behavioral health integration. So who are the practice team personnel that need to be involved at primary care level? It can be a care coordinator with BH experience, consulting BH clinician with prescribing capabilities. So psychiatric APRN or a psychiatrist, or having specific BH services. And then number 10 is health-related social needs screening and community supports. So screening for health-related social needs, maintaining inventory of services and supports in the community, referral and or coordination, or partnering with social service providers. There's more examples in the appendix of the material we sent. Just we wanted to at least give some examples to help kind of frame what each of these domains means. And a lot of these are already come up in the conversation this morning about, I think, future opportunities. So we're going to ask you now, take a minute if you haven't done so, and complete this survey. And what we're asking you to do is rank the domains for what you think the greatest opportunities are to improve primary care. And actually, Joe, you have a question, and oh, and there's another one. Okay. Oh, you might actually. He's got a phone. He's on it.
Oh, yeah. Just from my perspective, as a leading provider organization, we have to implement these things. And they're all wonderful ideas, every single one of them. But the context, I think, for me, that would be helpful is when we're ranking these or putting these out there, I think immediately, well, how would we do? And so what is the pathway we're going down, right? Because are we going to rank these and say these are things we want people to do, and then we're going to find a way to support the funding and implementation of them? Or is there or is it, which often happens the other direction, there's kind of a predetermined funding model that we're then forced to kind of work to. And we can't do all this. I don't know what of this we can do, and they all have costs, they all have
yes
and takes. And so it should be helpful to have that context of how you want us to do it. We want to just rank it based on what we think the ideal solution is, and then we'll figure out if there's a real economic, but we want to rank it based on what's most realistic from kind of the economics. And the final piece I'll add to this is that we also have to think through what are even realistic things that we can staff and support. Behavioral health comes to mind as well as, are there even resources to staff some behavioral health ideas that we have?
Great. And do you want to start?
Okay. Really good questions. So first, and I just want to interpret one question. First, there is not a predetermined thing. We wanted to start with the opportunities and the needs, and then we're going to talk about
Something happened with the sound. You have the laptop on mute.
And I'll just add, we have to start somewhere in terms of, one, we have to answer some of these questions first, and it does necessitate that we might need to come back to them in the future. So I just want to say that, adding on to what Guy's saying is that this is a place to start to thinking about, like, how do we want care to look? What do we want it to look like? What are the most important aspects? Realizing not everything we want to do is actually feasible for various reasons, I think. Annie.
So just as a follow-up to that last line of comments, when trying to deal with problem solving, quality improvement, functionality and order of process matters. If you don't have some of the foundational infrastructure in place to drive improvement, to give you the data, to, against the metrics that you're measuring, what came first, the chicken or the egg, does matter in process improvement. So, does process come before outcome, priorities? That's a tough balance, because you want to improve outcomes, but if you don't build the infrastructure, you're not going to get there effectively.
Very fair point. Thank you. Alice, I think, please jump in.
Thank you. I'm sorry, it's been a little confusing. I just need to say, as someone in the community who's been doing a lot of all of those things listed, from a medical model, I know that they're, sort of articulated as different models. And I just would counter what Joe said a little bit and say that there are models out there that integrate multiple of those initiatives, if you will. Right now, we're actually piloting a targeted case management population health model in New Haven that we just got the SPA approved, and we're training providers in that. We have an integrated data system that's using Unitas and Azane, so that there are ways of pulling in a lot of those important initiatives, in particular driven by the family or the individual, and that is wraparound New Haven, wraparound care. We also have very good cost data on it, and we have piloted in primary care settings some of the initiatives, but have data on that. And we are integrating care coordination, social determinants of health in schools. So it's almost like we don't have to start from fresh. There are things that have been done. DCF has been funding care coordination for 20 years, and there are outcomes, related to that. So I think it's just important to realize we have cost data, we have technical data infrastructure, we have population health, and we have a targeted case management already approved as a SPA in the state of Connecticut. It's just now for a couple of zip codes.
All right.
Thanks. I should do what Joe's doing, but I have not yet.
That's all right.
So I just have a process question, because we've got a lot of perspectives around the table, both folks who have more community perspective, hospital, medical group, and independent physician group, and that sort of thing, pediatric. And I'm wondering whether it makes sense to vote after we've had a chance to react to the things we're voting on and to comment on those, because I'd like to hear about sort of what people are thinking about why they would prioritize before we sort of lock into priorities. That's my concern. And I'm mindful of Dr. Dalal's attention to time, and so I don't want to delay us, but I'm really interested in sort of people's reactions to what's on the list.
Holly, I think.
So, to Alex's comment too, I mean, there's many things
I think some of this discussion is very helpful. And Mark, your question about, oh, sorry, is there, oh, thank you, Ben.
Oh, thanks. One of the things that I'm struggling with, I logged on with the little QR code and started sliding the things around. And don't get me wrong, I love to slide things around on the screen. But one of the things that I'm struggling with is that the goals that we've set out, those 6 opportunities that I think you've rightly identified, they're very different. And depending on what we are prioritizing among those opportunities, we might choose different interventions on the primary care capabilities that you've identified for us. And it also feels like the primary care capabilities could wind up shifting us towards a model that's very prescriptive about how we do the work instead of what we're trying to accomplish, and giving flexibility to the practices in terms of how they might get there. So wanted to raise those points, some of the challenges I'm having as I'm trying to vote.
Thank you, Ben. I'll just say, and in terms of, and in terms of how we've kind of ordered this, is this kind of, we're kind of just assessing where people are starting and then hoping to use that as a conversation piece rather than it's not like our vote that's a final vote. And so that's how we've kind of approached this, is kind of getting preferences and thoughts. With that said, I think it's reasonable for us to have a discussion and then ask people to weigh in if they haven't already. I think, again, it's kind of where are we thinking in terms of where are all of you coming from in different perspectives? And so we do value that, and we want to try to capture that in different ways. So, and I'll just say, Ben, I think one thing to your point about like what we're trying to do, I think, there is a question about like being prescriptive and flexible. And I think we are wanting to hear various perspectives. And I think we heard your perspective about maybe wanting to be more flexible. I'm not sure that's definitively where we're saying. I think other folks may have different opinions on that, and we welcome hearing those as we get to that part of the conversation. I missed Mark. I saw you.
Yeah,
Would it be possible to put the capabilities back on the screen that are the ones that we're focusing on? So what's striking about the list of capabilities is many of those have been around for 10 years, not all of them, but just about every physician group that's affiliated with a hospital, which is a substantial number of primary care docs, has a long-standing NCQA PCMH recognition status. They've been working on things like team-based care and patient and caregiver engagement. They have their family advisory councils. They're doing the best they can within the not 10%, share of the spend. So there's one of the questions I have is, you've been doing PCMH for 10 years in Medicaid. You've got a lot of PCMH enabled providers. They know how to walk that walk. It's really a question. And so the question is, do we want to focus on some of the core capabilities that are established and be voting on those versus more narrowly focusing on the issues? To go back to the goal, you establish biopsychosocial health and well-being of Medicaid beneficiaries. To my mind, A1C poor control at 36% is entirely aligned with the extraordinary disparities we have in morbidity and mortality between Black and white individuals in Connecticut. And so if you want to if one of our goals is biopsychosocial health and well-being, that's a big target and I wonder whether we should be focusing on the additional capabilities given the widespread use of PCMH, where we say, what would it take to move the needle on poor control for Medicaid beneficiaries with diabetes in Connecticut? And analogous to that, hypertension poor control, I know the measure is technically good control, is 36% as well. These folks are heading toward all sorts of unhappy cardiovascular outcomes. We see a lot of the folks who have downstream cardiac complications as a function of untreated or ineffectively treated hypertension. you look at the DPH data, the cardiovascular death rates are substantially higher for Black than white populations. That's an enduring statistic. And it probably cuts even more so in Medicaid, though I don't have that data. So when I think about, one of the questions for me is, do we want to think about these capabilities, which are sort of generalist capabilities that NCQA has been advancing for years, not HRSN, admittedly screening and referral for HRSN is a sort of newly emerging priority, but whether we want to, should we be defining more precisely what it is we want to move more effectively in Medicaid and build out the capabilities that are barriers to doing so today? And I really put that out as sort of a rebuttable sort of a question for folks.
Or you have the video, I guess. I'm gonna run. All right.
All right. So, Mark, thank you so much. And so I'll just tell a little bit of our secret here. That really is the discussion we've been having internally. Right. So I think you've really nailed it, that we are really talking about, let me just go back because my brain is working fast and I can get the words out. So let me stop for a moment. That is really the struggle. And I think you are hearing it articulated in these broad goals as opposed to very specific goals. So does that really make sense? And so I'm so glad you raised it, because I would love to have that conversation today. Because I think if we could, as a group here and there, really say, okay, you know what? In terms of what we are doing with primary care parent reform, or if we're incentivizing the changes, let's say especially the two examples that you just gave, that I think would really create specific measurable outcomes that can really change lives for people. So I'm happy to have that conversation, because I think that is the one we have really just been I guess, challenged by and wrestling with here at DSS as well. So thank you for that. Thank you for raising that. So we can, Brad.
I was going to say, I think,
Got a couple
Tiffany,
of-
did you have
Okay,
anything up?
we've got Ben and Carol.
There.
Carol,
And
Tiffany?
then Brad, I did want to go back and talk about the issue I raised with you.
Yes, definitely. The mic's better on that one, I think.
Yeah,
Um,
I'm Brad, you have to speak up some more. You're really soft spoken.
I will do my outside voice. Ben, do you want to chime in? And then Tiffany and Carol?
Sure. So I just want to build on what Mark and the commissioner have been talking about. And you know, I acknowledge that I'm relatively new to the work group. I haven't been with everyone the whole time. But as I reflect on the challenges that we've talked about most often that we want to try to resolve, it feels to me like there are three. The first is improving the management of and preventing chronic disease. And we've talked a lot about asthma, diabetes, hypertension, and behavioral health. The second is because we all have this focus on improving or reducing disparities, but we acknowledge that we have a data challenge there. It seems to me like another big thing that we'd want to try to accomplish would be improving the collection of race, ethnicity, and language data so that we could improve our focus on reducing disparities in the future. Not that we wouldn't try to do that in this phase of the work, but the more data we have, the better off we'll be in the future. And then the third thing is improving care coordination, especially with community-based organizations. So if I think about those as goals, I think that we could have metrics associated with those things, and we could think about how which of these primary care capabilities would support those the best.
Going to Tiffany next, and then Carol, have you next.
Thank you. And Ben, I appreciate your summary. I am fine with the idea of focusing on chronic conditions. I'm still questioning the chicken and egg situation, because can you appropriately address chronic conditions if you do not have care coordination, if you do not have the data, if you do not have some of the other even behavioral health integration, if you do not have those components integrated, can you effectively address chronic conditions? Now, if we want to start with chronic conditions to understand what we need to address these issues, that is a good starting point, but I don't want us to limit it to chronic conditions. So if there are solutions that work within chronic conditions, then we need to expand that across the Medicaid population. So that is where I would recommend, if we decide to go down that road, that we are fully understanding what is helping this population that could help the entire population. So more like targeted universalism. So if we start with chronic conditions, we need to make sure that we're expanding it. But we can't address chronic conditions, again, without the other components. Mm-hmm.
Carolyn, I know Commissioner will go to you after Carolyn.
Oh, no, okay, yeah.
Okay, so I have a couple questions again. I think I understand that this is all focused on chronic conditions and care management, but I'm noticing that accessibility of care is number 4. And accessibility is very important. And I was just wondering if we could put maybe accessibility being like at least number 2, but I think it should be number 1, right next to chronic care management.
Here, I'll just say thank you for bringing up, sounds like accessibility really important, understandably. These are just numbered, they are actually not rank ordered. And one of
Oh, I'm sorry, I thought they were.
That's okay. I'm sure it can, understandably, they're numbered, so it could, but we are asking, we will be asking if you haven't to actually rank order them, and so we would definitely welcome that. Right, yeah. Commissioner, could you turn it to you for a second?
I'm sorry. Okay. So I did want to just continue to raise up all of the issues that we're discussing, also particularly in the context of people with physical and intellectual and other disabilities, because I think that our community providers try to do the best that they can to deliver services and supports, but I will just talk about the 10 years that I spent supporting people with intellectual disability in particular. And what I will say is that I'm also going to ask the committee to also have a frame around the disability community, because what happens is that we create results or particularly desirable outcomes without really thinking sometimes very, how can I put it, specifically about the disability population. So the experiences that I've had in taking people to access primary care who have had disabilities is the process often lacks dignity. They will talk to me or the person that brings them in, as opposed to speaking to the person who's there themselves. They will not necessarily provide the greatest quality of care because they have made a determination as a healthcare provider what that person's value is in our community. They will decide, well, their cancer doesn't need to be treated. Their dental health doesn't need to be attended to, their whatever physical ailment that they are complaining of doesn't deserve to have the same degree of treatment or be taken seriously because this person does, I'll just say from my perspective, doesn't have the capability or I'll just put it very bluntly. Sometimes what I've seen is that the lives of people with disabilities are given less value than the lives of people without in the delivery of healthcare. And I just really want to raise that up and make sure that we are very clear that while we're delivering, that while we're contemplating what service delivery looks like, that we are also doing it through the lens of people who often don't have a voice for themselves. Okay, thank you.
Thank you, Commissioner. Maybe on that, I think one of our challenges is, I think, Mark, you kind of framed like, where we start with a case, there's a lot of cases we potentially could pick, and that creates some challenges in terms of coming up with solutions because, I think, and Commissioner, I think you said this earlier, like we can't do everything at once. We're going to have to start somewhere. And so we do have to prioritize. If we try to do everything, it's not going to go well for us. And so in some ways, we do have to pick and choose what we think the priorities of this work are for where we're going to go, and at least initially. And I will say, when we first started talking, probably this was a long time, in April, I think we said we are interested in phasing some of this work. Karen will get to you in just a second, because, do we think broadly initially about our primary care redesign, and then do we need to do sub work on specific populations, whether that's chronic disease management, whether that's individuals with intellectual disability, or various, or a separate program for children with specific diseases. I think those are things that we need to determine where we're starting, and then figure out what are we addressing subsequently, because doing all of this will be very, very difficult at the outset. Karen, I wanted to turn it over to you.
Oh, thank you. Just a couple of questions on the key domains. The one thing, and I'm not sure if it's a domain, but I'll just raise it, is probably within the next 10 years, primary care providers are going to be even more difficult to find. And if you don't have the primary care providers, it's going to be very difficult to do any of what's on the screen now. So I'm wondering how we address that. I work for Optimus, a federally qualified health center. So, we already see that difficulty. The second thing that I wanted to say is, I know that we're not prioritizing or ranking the key domains. However, I would think that the health-related social needs probably is the forefront for getting any of the rest of this done. Federally qualified health centers already do a lot of this, and perhaps it's the model to study. Our patients in the communities we serve have many social determinants of health that prevent them from getting care in a timely manner. So in addition to that, we also work really hard to develop trust within the communities that we serve, because sometimes medicine is not, they don't trust, what we're trying to achieve and trying to help them. So I think we have to factor that in as well. But again, I will just put out there that I find this interesting, but it's a lot of stuff that FQHCs do every day, without any compensation for that. Because there's our billable visits, but we do hire community health workers and the like to be able to connect our patients with services that they need, so that they will feel that they can come in and receive the care that they need. So thank you. Just wanted to put that out there.
And Commissioner's going to say, and I just want to quickly say, and sorry, getting my chest, is that we are specifically talking about number 10, the health-related social needs, separately, just because it's been such an important topic. So it is something that in our next discussion actually will be the focus. And we specifically pulled that out because of the need there, Commissioner. Yeah, later this morning, the next topic.
Oh, Karen, I had a question for you. Okay, all right. IT can't come fast enough as far as I'm concerned. Karen, I have a question for you. So based on your experiences at the FQHC, how would you inform the work that we're doing today, given the comments that have been made that Mark has raised up and what you've discussed about what you're already doing? What would you advise at this point in terms of what we should prioritize in this first phase of the work that we're doing? Since you're already doing it, where do you see what would you recommend as a starting place?
That honestly, I'm sorry, it's hard for me to say because it's been very difficult for me to hear. So I really can't comment. If you wanted to ask me something specific, tell me something specific that was said, I'd be happy to respond.
Okay. All right.
I mean, honestly, the people that I could hear are the people that are online or the person that is speaking at the microphone, but I could not hear anybody else in the room. Yeah.
I'm sorry, Karen. Yeah. So if I could, let me see if I can.
So I said that it was Olivia's laptop. That was.
I see. All right. Can we take it back over to Mark so he can repeat what he says so that Karen can respond? Is that what we want to do?
I think were you asking Karen to respond based on her comment?
No, I was
Or
asking
on
Karen if she had
Mark?
feedback regarding a Mark's suggestion.
Got it. Okay, okay. So Mark, can you repeat your comment?
Right.
Thank you. If you don't mind, I'd like to repeat my comment with an addendum, and I'd like to go back to what, so Guy opened with, we can't, this may not be your terminology exactly, we can't boil the ocean, right? We're right from the start, we want to build out capabilities over time. And Tiffany made the comment about, well, we don't want to focus on, say, chronic care management and neglect care coordination or parent, patient and caregiver engagement and that sort of thing. And so, so basically, Karen, my suggestion was as a sort of, as an idea was to focus on two of the conditions that have the biggest impact, setting aside behavioral health for a moment, on the long-term health and well-being of Medicaid beneficiaries might be diabetes and where I think there are prevention and management opportunities, and also hypertension. And that would allow us a small set of measures to begin with that are very focused, and we can build out these other capabilities in the service of that. So if you're hiring health coaches or community health workers as navigators, you're hiring them initially in the service of a particular role and function in support of a couple of chronic conditions, and a behavioral health specialist who first and foremost is focused on the comorbidities, which are so common for those conditions. And so that would allow one to ensure that you're touching all these other important bases, including the data that Ben and others, Polly, have referenced are so important, including the disparities strategy, right? It allows you to do a sort of test run around the track in a very focused way. I'm assuming you're not just going to go up to 10% all at once. So if you're adding money to the system, it's adding money to the system, folks building in certain capabilities that touch on a whole set of these, including the accessibility issue, and then building out from that. That's what I was putting out as a as an idea that a few minutes ago.
And Mark, I'm going to just respond. I'm not opposed to that. I think that might be a good strategy. My concern is that we often stop. So we will work on chronic conditions and then stop. And there are things we'll learn through that approach that will help the entire population. And so my point is that we cannot stop after we see improvements in those. We need to be assessing what helped improve those populations and then apply it to the broader Medicaid population. That's where I'm going with it.
And I, hold on one second, I didn't see any other hands up. Karen, did that clarify part of the question I think the commissioner is trying to pose to you in terms of like, where do we start? And somewhat, does that help? Maybe you can hear better now.
No, that I did hear. And thank you. I'm not sure. I think I would have to, I think I would need more information before I could actually answer that question. Because I think there's a lot of factors at play, you know, and I'm not sure, you know, for how we operate and what that would look like, what that would mean, you know, could we do it in the confines of how we operate now? I just think that, you know, we talk, my point was, we talk a lot about, I looked through the slides last night and I think about this and I thought, wow, this is all the stuff that we were already doing. We don't have to invent the wheel. Does it need to be perfected? Absolutely. Does there need to be significant improvements? Sure. But I think, you know, when we look at the disparities, you know, we see those every day in the populations that we serve. And we really try very hard to address that because we know that this is important that they get healthcare. And you could look at diabetes, you could look at asthma, you can look at nutrition, you can look at behavioral health services. But again, I think if you're going to start that way, you probably, in order to get a good feeling, you're going to have to address everything around that. In particular, one is going to be access to the social determinants of health at a minimum. Because currently we can't, I mean, you know, I think you had other interesting slides in there about how close Medicaid population is into primary care. That may be true, but for our patients to get in, to get an appointment, it's very difficult for them to get an appointment, you know, in less than 3 weeks. And that's for a variety of reasons. Some of it's because, you know, you can't hire quickly enough. Other, you know, is the transportation, so other social determinants of health. So, sure.
Thanks. And Allison, I think Joe, and then I might say we'll actually ask folks to do your rank order at this point. So just for timing purposes, again, like this is just we're just trying to feel out where everyone is at the moment, rather than saying like, this is the only time. We're trying to, again, prioritize. We know all of these things are important across the board, but we can't do everything. And we do value your input as terms of like, where do we start with prioritization? So Alice and then Joe.
Yeah, I would just say, Karen, thanks for what you said. And I know that FQHCs do an extraordinary amount of additional federal funding and grants projects to be able to deal in to address some of the chronic conditions that are there, so that there's multiple forms of financing that appear within a lot of our larger organizations, and it's not fully funded by Medicaid currently. So I know you don't really have funding as a domain, but I do believe that a lot of these issues are issues that span across multiple domains other than DSS and Medicaid funding, and that we need to have some sort of funding, braided and blended funding discussion to be able to address this. And that may be down the road, but I think it's also important to bring up, from the beginning.
Can I just say one quick, I think one of the things we haven't talked about today as much, but we had listed and kind of goals and strategies is like multi-payer alignment, recognizing the need for that and of an interest. Josh is here from the Office of State Comptroller, and we've talked extensively with other state partners, and I think we're very interested in that as well, recognizing like Medicaid and CHIP may require a specific, or we might want to have something that works very particularly tailored to our population, but also recognizing there's opportunities for alignment and trying to align when we can. So just wanted to throw that there, I think. And we will get to payment. We were kind of starting with care delivery, and obviously these things are braided and they do sit together, but it will be an important part of the conversation is funding. Thanks, Joe. Representative Dathan.
Sorry. Oh, apologies. No worries. I'll repeat for those online.
It's Lucy Dathan. I represent Norwalk and New Canaan in the legislature, and I on MAPOC. But I'm also very interested and wanted to thank the commissioner for her comments on the intellectual and developmentally disabled population that is having access issues. And I did want to highlight that the Connecticut Council on Developmental Disabilities is doing an excellent speaker series this fall to talk about this. And I'm really hoping that as part of that discussion, when we're talking about accessibility, that we are working with that council as well, so that we can make sure that everyone does have great access. So I think it sounds like there's people nodding their heads, but I'm really encouraged to hear that. So thank you. Thank you, Olivia.
Thank you. I think Angela, and then maybe we'll cut comments there, ask folks to do some voting, and then we're going to take a brief break and we'll come back. NIT, great. Great. Yeah, so we do.
We do. Earlier, I think that it could be even stronger by data collection and other things. That's especially in CMS. We're not the only state that said we can make those standards much stronger.
And we actually will have a conversation about like flexibilities versus how flexible versus how structured we want to be. And I will say, if you look at our existing PCMH and even PCMH Plus programs, we have pretty specific requirements to participate in those programs, provider requirements, in addition to just being a Medicaid provider in general. And so that is there, but it is something that we do want to talk about today as well. Because there's obviously trade-offs with doing both of these. And sometimes we may want to be more flexible, and sometimes we want to be more structured and have more requirements.
But I think that would take the mask and the if there was a standard based on it for everyone, I think the expectation would be a little bit more reasonable. And we can really get to the root of that.
And maybe that's a good, maybe if you don't mind bringing back up at the last conversation, because that actually pertains very, I would say, somewhat directly to that at that point. So I think we'll ask folks to fill out the survey. And again, this is not a like final vote. Oop. Oh, code, yep.
I think the other just broad process point I'll just briefly offer, because I think there's been a lot of conversation related to it, and Brad has said it, but this is not a vote, right? We're voting, but it's a sort of, here's where you are now. And I just want to acknowledge, right, there's been a lot of conversation about, well, when we get to performance measurement or when we get to payment, right, we might think differently about these things. And so just acknowledging in terms of the sort of macro structure of this process, we will get to performance measurement, we will get to payment, and that means, you know, these are interacting pieces. And so we're pulling them apart a little bit in this conversation, but this isn't a final answer, right? Because we may have to go back, you know, when we have a conversation about performance measurement and say, oh, we're not sure we got that quite right, right? Is that fair? I just want to offer that as people are doing the exercise.
Great.
QR code is on the screen. Links have been sent out. If you have trouble, raise your hand. We can enter responses from our own devices. If folks on the Zoom have trouble, please raise a hand or chat, and we can help you submit a response as well. And then we'll generate results pretty quickly and take a look at them together.
So, and then we'll come back we'll take 10 minutes and we'll see if we get, we'll work on, see if we get anything fixed on IT. So thanks everyone. And we'll see you at 10:05.
And we talked about that.
Yeah, so they can just down.
Yes, now.
Have one of them talk.
Yeah.
Yeah, can you all hear me?
Appropriations.
No, no. Yeah, adolescents.
That's good.
Yeah, anyone.
Yes.
It passed. In our town, we started smoking. Started earlier than.
But we're missing already advocacy.
Can you all hear me?
Sorry, I'm not.
We do that, we used to have.
Volume control map should be all the way up.
Medicaid advocacy with every year, like 20 years, we gave them.
Good Graham, so we just, when my son's a swimmer and he's the same way, very just. It's much of it's gotten resolved, it's just, well, this is.
It's like he can't.
Yeah, 3 hours are rowing.
Yeah.
Folks, you would say, "Wait."
He'll come home. And I'm like, I haven't done it. I know. Yeah. And then my.
There should be a sound setting.
Yeah, no, I think about what it is now, CCPD is only getting.
It is. Every night. It's tech going in there. That if
Data from Boston. We actually have consolidated for you.
you're not thinking.
Another. Data, so it's really hard. We're trying the same. Right, they're doing another level of analysis. So. Clinically, it's just our.
Yeah, that's what we're trying to do. We're trying to find an answer. It's like, okay, we already talked. Yeah.
Yeah, see if she can talk.
There's a gap, so we.
We're an organization now.
60% of.
To see what organizations are out. Providers. Like I said, we really need to see them. Yeah.
Sure. Can you all hear me now?
So people started.
Specific.
Okay, great. I think I heard a yes on your end.
Yeah, that's good.
Yeah.
I mean, we will fund and if you have some suggestions. we're
So-
You know what, you know that too, but because social connection is so.
Because everyone's-
Adolescents, right?
You know, it's really easier to.
Yeah.
I mean, so my son plays games.
Yeah, there's, I think the attribution line, one issue. So we moved to New Jersey years ago. Usually
Yeah, we hear that. Yeah.
and
We don't hear that one. Yeah. We're gonna solve this.
they're almost their whole lives, all their life.
That is,
As a pediatrician, I never thought.
that's them hearing us.
You're right. Like it's.
Audio, recognize that.
Be able to keep their. We're building new.
Yeah.
relationships here.
It's a little.
Now they have.
Right, but everyone else talking. Yeah.
So in some ways.
I mean, I will say that.
Starting in a few minutes, right?
Yeah,
Yeah.
yeah.
No problem.
I get I know. That's.
Kind of hard to keep that on.
Laundry list, example, that's. They just keep again, trying to find it.
Yeah, so I'm gonna right now to use like the built-in microphone and speakers in the room. Yeah, I had to read something, I'm sure. What else you were-
That sounds interesting, that like
guessing.
You get what I'm saying?
Wow. And. Good save. Thank you so much for making the.
I know it's a real.
No, it was.
Especially if you're not
There
gonna
was.
look.
Yeah, I mean, I think like.
I push for.
They need to figure. Yes, it was. Yes, I'll be.
But I do think.
My goodness.
And again, even for next year.
Thank you.
But anyway, no,
That's what I
You live in New Canaan or?
Yes, the dollars, so our.
Yeah, yeah. I mean,
Like, if there's.
We'll do that drive.
Oh, yeah. Today was like.
Trying to raise.
Build up my.
Awareness.
Sitting there.
He's the rough room.
Yeah, exactly.
You ever, it takes discussion and you.
Yeah, yeah.
What would let us know? So how do we know this is working?
We actually just tested it and you could hear them. It's faint, but you actually could hear it. I think that's probably not safe.
Rosters.
Great. Good, everyone.
You get the.
I think it.
Sorry, I know they get you. All right, we're going to reconvene so that we can stay on time. I know it's a long morning. I need my Medicaid director to set a good example.
Very much. We need.
Yes, we do.
All right.
Hey, sorry, confirming on. It's okay.
I didn't know that our data was there.
Make sure. Either get a thumbs up or. And, I might ask Hannah, who I see is highlighted, if you would talk for just a minute, just to see how well we can hear you.
Sure. Can everybody hear me okay in the room?
You're up. You can hear up. We just asked her.
Okay.
Yeah, we can hear you. It's a little far away, but we can hear you on our end.
Okay.
We
speak.
Much better.
Thank you.
Oh.
Write down the page and put it on.
Yeah, no problem. Okay, sorry.
All right, everybody thank Mike. Thanks, Mike.
Sorry you had the trouble.
All right, everybody. So thank you for the initial great discussion. I think I know health related social needs came up quite a bit. And so our second topic is specifically on health related. And so again, we're going to kind of briefly review a spectrum of options that what that could look like. And then we had initially planned on asking you to vote first, but I think we'll move that to the end as we did last time. And we'll have the conversation, but we'll discuss what that spectrum can look like. And so these are the two questions we're asking to discuss. So what role do primary care practices play in addressing health-related social needs? And what tools or supports do primary care practices need to support patients who have health-related social needs that are impacting their care or outcomes? And so here's a spectrum of examples of ways that primary care can play a role in addressing. So you'll see here option one on the left in the purple box is primary care practices have no responsibility for identifying or addressing health-related needs. Obviously, that's somewhat the world today, but not totally. There's places that do have to start doing this in different payment models, but that's generally speaking where we are with some movement towards two. Option two is primary care practices are expected to perform certain functions related to screening, referral, and or care coordination. So again, there's a lot of new models and payment models, including folks in our state who are doing this now. Then option three is primary care practices are expected to deliver select health-related social needs. So actually addressing some of those needs themselves. And that's pretty rare at the practice level right now. Not a lot of practices are doing that. And again, it is happening in rare circumstances. So that's really option one, no responsibility, to option full responsibility. And there's some blend here. Guy, did you want to add something?
The only thing I'll add, I'm going to speak loudly so folks online can hear. Option one is not meant to be a straw person, right? Option one is saying the primary care practices won't address health-related social needs. That doesn't mean that the Medicaid program outside of primary care wouldn't, right? You could imagine addressing social determinants of health outside of the primary care setting. So I just wanted to call it, we've heard you, social determinants of health really matter. And I do think option one is a viable and interesting model. I'm not sure it's the right model, but I'm just calling it, it's not meant to be a straw person. I think it's something to really take seriously.
And I'll just say, we definitely heard you on the need to do that. And we had that session over the summer. And we're continuing to explore opportunities to address health-related social needs through 1115 process, as Guy had brought up here, as well as in MAPOC. So just to give you some idea, oh, sorry, Commissioner, please.
I also just want to continue to emphasize, this is not the universe. We were just trying to create some framework so that we can have the discussion. If none of these options work, and that's part of our discussion today, as well as some blending of these work as well. I just want to continue to say that that's what we're doing. I'm sorry. Thank you for that.
Thank you. So these are some state and federal programs that have specific ranges of how to address really social needs, and really mostly under 2, as you'll see, and really under 2. So on the left-hand side, you'll see that's what's the care delivery requirements, and on the right, on the x-axis, you'll see the different programs. We're not actually going to go into each program here, but just so you have a frame of reference for what is being required in some circumstances. There's more than this. This is just what we wanted to bring to you and as illustrative examples. So on the left, again, you'll see the screening for health-related social needs. We've talked a lot about that. You'll see maintain an inventory of services and supports in the community, develop and implement referral and/or coordination workflows, partner with social service providers, utilize CHWs or equivalent professionals with shared lived experience. So again, just some examples really under option 2, and not actually getting to asking it themselves. So we're going to come back to this. So this is the voting we did just before. We're going to come back to this and ask you again. Again, this is just a kind of a temperature check. Where do all of you think you should be headed with this work? And so we do want to now open it up to the conversation of what role should primary care practice play in addressing health-related social needs. So I'm going to open up the floor. Please feel free. Anyone want to start? Mark?
So,
you got this best you can.
all right. I was actually pausing to see if Polly wanted to start because she chairs our HRSN working group, use the sort of current term of art, and has for a couple of years. So the hospitals have focused on screening and referral, including the use of one or another platform for enabling closed loop screening and referral. And although Find Health is not entirely closed loop yet, I think it's heading toward closed loop soon. And I believe that most of them are looking at moving to the enterprise, including their primary care networks that serve a lot of Medicaid beneficiaries. I think that as an association, our members are 100% in support of the importance of screening, referral, and closing the loop. And so option 2 seems like just an essential element, especially if one is focusing on chronic condition management, which is so often SDOH is not SDOH, HRSN are a barrier. But I think that the providing of social services is a bigger need to be addressed because there are many other parts of the care delivery system, including hospitals, behavioral health providers, and the like, where needs are identified and capacity needs to be provided.
Smart. Any responses, thoughts? Joe?
Yeah, I mean, I agree with Mark on his assessment of the option 2. I think that from a provider perspective, the most challenging aspect to this issue is not performing screening, is not engaging patients on that. And I think it's been done historically for many years in a broad swath of providers. But the common refrain is when I screen and a patient screens positive, I don't have resources or access for something to send people to. And I think that creates a negative reinforcement to do the screening initially in providers. And it's obviously an unhealthy cycle, but that is the reality. So I think there's actually desire for providers to make this the routine and standard part of their practice, as long as we can provide the appropriate support services that they have access to. The final issue I'll make about this topic is that this is an area where data collection
and evaluating performance and compliance is exceedingly challenging. The current model and the current systems that are in place do not do a very good job at allowing us to actually track this measure. So, and that's should be beyond the scope of what we're talking about, but as we put this into place, we'll have to consider how we can actually meaningful measure provider and group performance in this.
Bill, can you say what those methods are?
So what I'll refer to is that under kind of typical claims-based data, the options that are available to submit data on this topic are fairly limited and fairly narrow and don't even currently include a negative screen at the current point. And so that creates those challenges. So then the other option would be we put the onus on providers to begin to document, collect data in electronic health record systems. And that's an emerging opportunity. I don't think that's fully developed on the provider side as well. So the traditional EHR-based measure set and the claims-based measure set on this topic, I think, are not fully developed.
And then Polly, get you, CJ, actually your hand up first, and then Polly. CJ, please go ahead.
Yeah, thank you. I think that in considering health-related social needs, it's very important for primary care providers and practices to recognize their role in terms of equity and representation, right? And so that includes ensuring that we have staff that looks like who they are providing services for. I don't think many of us could disagree that right now we have an unfortunate situation where too many Black and brown people are not getting services, and that's very concerning. Particularly because of what they're using to self-medicate and how they're doing that. So I would like to see a greater awareness in that sense, and for, folks to take more accountability where that is concerned. I'm not going to say that we're always going to agree, right? But this is an opportunity to improve. Let's start employing, training, recruiting purposefully, meaningfully, Black and brown people, so that we could encourage folks to take care of themselves again. Thank you.
You guys hear us online again? No.
They should be able to hear us now. Can you hear us now through Brad's laptop?
Yeah, we can hear you through Brad's laptop. Can you hear me?
Off of.
Am I good?
Olivia, we can hear you. But I'm not sure you can hear us.
Yes, we can, and I think we're in better shape. Sorry about that. Polly, sorry to interrupt. I think we're in good shape. All right, Polly, go ahead. Sorry about that.
So I think where we've seen, the community capacity piece is absolutely a challenge. When we think about making referrals and having, a large health system and a network of providers, like there's processes in place to make that happen. And a lot of the community organizations are, independent 501c3s. There's less infrastructure around that. So I do, worry a little bit about, when we bring the community organizations to the table, because there is a wave of not just in the Medicaid program, but in other programs where these are increasing expectations. And we absolutely want to provide those services. I think the role of the CHW has been incredibly valuable. I think particularly in helping to navigate to even some of the state programs that are available for completing applications, to going out to the homes, doing health education. They can support patients with diabetes. So I wouldn't, there's so much that has to be developed from a resource and a network perspective. So, you know, I absolutely echo the concern that if someone screens positive, what are we going to have to offer them supports? I do think there are unique supports that are available to Medicaid beneficiaries that might not be available kind of to the broader population. And we found the roles of the CHWs being incredibly helpful in helping individuals ensure that they're getting access to the benefits and services that they are eligible for.
Did you want to? Maybe a follow-up question for both our providers and the members and advocates. Are there, as you know, some Medicaid programs in some states are starting to more explicitly cover social determinants of health spending. We'll put that aside for a moment. Under our current structure and program, are there things that we at DSS could be doing better to help with that key step, which is, you know, a member comes in, you screen, there's a gap, and then you want to make the referral. And there may or may not be a community organization that can catch it. There may or may not be a state program. Are there things that we should be doing better to help in that key moment?
I mean, the short answer is yes.
I'm not surprised. So
I'm thinking,
tell me more.
so I mean, the problem is the breadth of social determinants is
Yes.
large. And so
Yes.
I'm just thinking through,
Yeah.
so let me give you the idea. I mean, the ideal state would be, would work from there is that when a patient or family screens positive for an issue, that there is a kind of a predetermined referral source that is, again, back to the same issues, accessible, available in a timely fashion, in proximity to where the patient and family live, that can address those needs. And I think that, that's a challenge. So I think, and the question is, which of those, you know, you can provide support for, which are already there and we just don't know about. So I think the first step that comes to mind is if there are resources that are there already, which I suspect there are some that providers generally don't know about or don't have an easy method to connect to. That seems like the first goal to try to solve.
Kind of a guide to providers of here's the resources, the guide would have to be up to date and things like that. Okay, that's really helpful.
CJ, and David, and so CJ, please go ahead.
Sure, thank you. It might be easy to sit here and put the majority of the accountability on DSS, right? I think that is a go-to. I think that has been a, lack of a better word, a trump card. But I also think there's ways that DSS could get support, not only from the community, but also from agencies around it. I think that in particular, DSS, you know, when clients are coming to you and they're flagging concerns about providers and how they were treated, those should be followed up on. They should not be ignored, because part of the problem, as was previously mentioned, a lot of Black and Brown organizations do not have access or even know of certain resources and so forth, because we have bigger actors taking up that space and they're not being held accountable. So I think that DSS could do a little more with the accountability piece, not take all the blame, right? I don't think that's how this should be happening. I think that there should be some sort of metric. If providers are supposed to be part of the system and you have X number of CHRO complaints, let's start looking at that, because that impacts how they provide service. And I feel like when we talk about accountability and DSS, we need to talk about that piece, because again, I can tell you of stories, which we don't have enough time for, where people would go into DSS and they would take out their anger from their experience on the DSS employee, right? And I'm not here, listen, me and Ned Lamont not BFFs or nothing, that's not what I'm here for. But if this conversation is about addressing the issue, let's talk about it all. And let's deal with it once and for all, right? And I think we could do that, and I hope that we do that. And I really hope the cry for representation is not just a cry, but it's lifted up, because we have so many people, Black and Brown people, who are qualified, that could do this work, that could connect with the community. Let's make sure that we respect and understand and welcome our community health workers, because they're a very big part of this, right? And I can also tell stories of, you know, community health workers who are doing intake for people, but they're making the same amount of money and they're going through the same lived experience. So that's another thing to think about, because we have employees who are dealing with people and they're going through the same. Just putting it out there. Thank you.
CJ,
I just wanted to, in some ways, this is a encouragement of what's already been said, but I think the key, as I think about this, we're not going to be successful unless we have the ability to screen, refer, and link. And so I think the primary care providers, or at least the primary care practices are built and good at the screening and the referral, or can be very good at the screening and referral. It's the linkage challenge that I think is very challenging for the primary care practice, because as we've said, with limited resources in the community or limited knowledge of the resources in community, the time that it takes to make those linkages really requires someone who can do that well. And what I'm hearing CJ say is there are people in the community who are very good at this. They are of the community. They know these connections. And so if there's going to be investment, I think it's not only in the availability of those resources, but also in the availability of the people who can do that linkage work. Otherwise, I don't think we're going to be successful in any of this.
I think Tiffany and then Polly and then Martin.
Yeah, so just thinking about a similar approach that Mark raised in the previous discussion, and in a way to maybe back into the capabilities, I'd be interested to hear in terms of a relative burden of the different health-related social needs that providers are facing. And then maybe we can back into what are the capabilities are needed. And it seems like the capabilities are on the linkage and also on the community infrastructure side. So, I mean, we've obviously heard a lot about housing, but I'd love to hear what folks are seeing on the ground in terms of specific types of HRSN that they're facing.
You want to go to.
I was gonna actually have, if it's okay, go to Tiffany and then Polly go back to you.
Oh, I didn't know if Mayul, if you were looking for an answer, that's why I was pausing from the providers.
From our data that we're capturing, about 10%, and again, it varies across all of our delivery networks, but about 10%, and this is not specific to Medicaid, I can get specific Medicaid numbers. About 10% are screening food insecure, about 5% housing insecure, and about 5% transportation insecure. So what we've heard from our community health workers and what we've been talking about is, like, can we think of, food, which is a more, direct thing that we might be able to influence as, how do we build programs around food insecurity? Housing probably has the most, it's the most challenging for us to address, but also can have the biggest impact on some of the outcomes. So, it might be, to Mehul's question, like, do we pick, while we have to look broadly, do we pick an area like hypertension and diabetes and food that might be a starting point to say, how do we lift those programs up and build more complete programs across all of the areas to serve the patient populations? And then how do we take a more challenging thing like housing that's going to take more of a long-term viewpoint?
Sorry, Tiffany, you want to respond?
No, I had another comment, but I just wanted to make sure that Mayul's question was addressed, and I think that is a good point. And the sense of looking at where there are the most significant needs, because it goes two ways. How can you develop the right community partnerships to address the immediate needs, but how can Medicaid think further at some of the innovations, 1115 waivers around housing and other things to address those longer term needs? So I just want to comment on that. But my comment was more so, I am curious as to how not necessarily the large health systems, but the smaller practices are thinking about their team-based approach to care. I think we need to be realistic around what we are requiring of primary care providers in a 15-minute visit with individuals. And how do we broaden the entire team and provide the appropriate funding for practices to have what they need to address the needs of their patient population? So I am just want us to be aware of what we are requiring of providers in that short frame, but solutions that don't necessarily mean that they have to be the ones that are addressing every single piece of the needs. There are folks who can do that. In addition to that, I'm going to go back. I started the data conversation. The data is so critical, but we have to think beyond the data that is shared with primary care providers and health systems, but the data that's also shared amongst community-based organizations. So how do we expand the data infrastructure so that, for example, when I visited Minneapolis, their housing authority had access to the EHR system. That is a totally different way of integrated care. So before they knew when somebody was exiting their ER that had homelessness or housing issues, the housing authority had access to that data so that they can provide the services. We also need to think about this as being more of an integrated system outside of the Department of Social Services, and think about the data infrastructure that's needed across agencies, but also across the community-based organizations to fully close the loops.
I think Mark and then CJ and then Mark and Sally.
Holly, did you incorporate into your response to my poll what you had?
Yes, I believe I did.
So, I think that's an interesting, idea, Tiffany. The thing that I've been thinking about in terms of, assets, that exist today, two under DSS's control and one not. One is, 211. Which is 211 is effectively utilized as it could be to work the linkages, which is where time and effort is needed. So for Child Development Info Line, you probably know it better than I do. They serve a function of a linkage function that takes the burden off of practices, because the referral's been made and there's somebody who's making sure it can get tracked. And for all the the interest in and efforts to make Unite Us and find help a success. Unite Us has some challenges. For example, smaller organizations are not equipped to participate as providers, and consequently, CHN Connecticut's experiences this. I've talked to the QHCs, I've talked to the hospitals, I've talked to CHN Connecticut, who's the biggest user of Unite Us, and they basically say 2,000 of their 16,000 referrals, they can use Unite Us. For the others, they can't, because of network adequacy, because they're small entities with high turnover that simply can't integrate into the Unite Us network. That's a big gap. The other thing is on inpatient capacity. Probably what I heard from hospitals was when we do a discharge plan, and even though this conversation is about primary care, your primary care diabetic patient has a short-term complication, ends up in the hospital. It's the hospital that has to figure out what the barriers are at discharge. And so if they can't, you can secure an appointment with a cardiologist and that appointment's made, but if you do Unite Us, they're supposed to be discharged tomorrow. Unite Us may not get back to you. You don't know whether they actually have a landing place for several days. So the question in my mind is, does 211 or CHN Connecticut, the other big asset, provide an opportunity to diminish the need for for the providers to work these cases, such that you can have a certain degree of confidence that linkages will be made, even with the smallest providers who don't participate in the platform. The other thing that I would offer, a conversation we've had is there a way, and this maybe goes in the parking lot, to capitalize on the cross-sector collaboratives that exist, that hospitals convene often with health departments, that are intended to advance regional strategies around health needs, and that's where, and broadly. And is there a way to partner with those collaboratives and even have a funding solution that enables them to develop the local solutions? Because it's really hard for a 211 or a CHN Connecticut to work the region. It's the local actors, I think, that understand where the particular gaps are, but also the opportunities to help businesses, the CDOs, grow capacity and that sort of thing. So three thoughts.
Or just if that was the one piece of my comment back that I meant to make was that, we may see the data and we've been working with providers on like the adoption of the workflows and incorporating that. But then I turn to my partners in the Office of Health Equity and Community Health that have the relationships with the community organizations that are looking to now take that data and think about how do we, grow those partnerships? What do we know about the data that we're having? So, thinking about all of those assets that we have across the state, whether they're in the health systems, in some of the, community organizations that have these other collaboratives, and, how do we bring those in more directly? Because I think it is going to be a partnership model, beyond primary care to actually build up the capacity. And those organizations have community health workers as well. So there's also like, how do you build a team of teams across those organizations that get to know the patients, that get to know the communities? So that I think one of the things we also hear is, we don't want to be putting in resources that kind of then overlap with resources that might be being developed in 211 or being developed in, other parts of the community. So I think having ways in which, those groups can partner together, share information, and kind of co-develop what the solutions need to look like would be, my thoughts on how to move some of this forward.
You go to CJ. So I think David Kroll, did you have your hand up too? No. CJ?
Okay, thank you. So I just want to just start with saying, let's not just pass the solution off to somebody else, because in my opinion, speaking as a Black immigrant, that's what happened to DSS. We kind of said, oh yeah, we need to do this, give it to DSS, right? Same goes for 211. Here's the thing, when you call in, the clock starts. That puts a lot of pressure on providers. Sometimes they can't get there in time. We're creating processes within processes. Let's think about the process first, right? Let's think about that really carefully, because while I respect 211, I dare say right now they are well above capacity, and they would also need support. So it's kind of like the blind leading the blind, in my opinion. The other thing I'd like to share is in terms of data collection, because that's the term that keeps coming up. I don't know if most of you know, but it is quite likely that folks are not giving you true information. Why? Out of fear of what it might affect elsewhere, right? So like if I go to the doctor and the doctor's telling me, well, here, we need to screen you, we need to ask you these questions. What if the school just called me in because my child was acting up? Are you going to use that against me? I'm just trying to give a very vague general idea of why some of this data might not be what you may want or have, or it may not be true at all, right? Some folks have fears of getting tied into another thing, right? Like if I'm honest about certain things, does this mean that I'll get sent to court? Does this mean that I'll get arrested? Does this mean I'll get detained? Does this mean that DCF is going to show up here? Right? So it's like an education piece, right? Because I have people who say they don't know where to go. They don't know who's given what. They don't know if I go here, will I get this? The cross-section part, maybe having access to information is great. It is a very good idea. But let's not forget our private and small practices that are already struggling. Many of them do not even have or are not even to par where they should be because they can't afford it. Right? So I think two things here, education and resources, and careful thinking about how we spread it out like peanut butter. So before we do that, let's think about that. Going back to 211, if you have a physical disability or mental unwellness and you're trying to connect, that could just add to it. So again, let's just putting it out there for consideration. Thank you.
CJ, Mark, I was just going to add, I think that brings up an important point about how we're asking the questions becomes really important. Who are trusted messengers in our providers? Who's the person asking? And I've been to my own, I'm a primary care provider. I've been to my own primary care provider. You get screened by the MA for depression or other things. Is it someone's just checking the box, or they actually really care? And I think that's an important aspect as well. So I just want to say thank you for raising that up, CJ.
Yes, and I just want to add this one point, if I may, really quick. That is big, because that's another thing that's coming up. There's so many people who are struggling right now in Connecticut. It is very frustrating when you have to go to the doctor to these questions, then you got to go here, then you got to go there. So thank you for raising that part, because that is adding not only to people not engaging, but not providing accurate data.
Mark? So.
Yeah, I was thinking as Tiffany was talking earlier, and this may be a parking lot issue, and also I think CJ sort of addressed it, but Tiffany said the need to be realistic of what we're requiring of small practices. And I think this is also relating to the key domains, and however we ultimately decide what the strategy is, what are the organizational and practice capacity and readiness issues that will be required to implement our strategy? And I really think we need some instrument that can assess readiness and then have internal teams that can help with the implementation to achieve where there are gaps. And obviously that all requires financial resources. But we have such disparate capabilities within, we have large hospital systems, we have very smaller practices and lots in between. But I think whatever we alight on today and moving forward, we really need to figure out how do we translate these key domains into what that capabilities are in an organization. So I really worry that we don't have a strategy there. We'll have whatever we come up with. I'm sure we'll have good ideas about things that we want to do, and I certainly align with where Mark was earlier in terms of focusing on diabetes and hypertension. But then the real need to figure out the core capabilities of practices and organizations and then help them move up the ladder.
Thanks, Mark. Yeah. Angela?
Yes, so I just went through an exercise while listening. If you're looking for clinicians to make referrals, what are they using as a database to pull from? Right now, I did a search for behavioral health in the area that I served, 06120 zip code in North Hartford Promise Zone. And the providers of color that would be most likely to provide some level of cultural competence with addressing issues in our community are not in the database. So how are physicians, where would they come up with this referral system? I would imagine DSS providing a platform for those entities, particularly those of color, to opt in so that they can be found. But the system that's in place now, I don't know what they would be using to find these providers. I could, My People Clinical Services, Build a Better You, they're right in the heart of the community, providing services, they're not in here.
So thank you, Angela. I think speaking to the tools that providers would need and also other capabilities that may need to be developed to actually operationalize those tools. Other thoughts on that, Joe?
Just want to circle back to an issue I think was mentioned previously about what we can expect providers, particularly small providers, to actually resources they can build up and develop in their offices. And just a general comment, and because I've been in other work groups and experienced other work groups where the work product has come up with almost unachievable requirements on primary care groups. And I'll speak to the word integration that we use commonly, and how that gets defined is an important one. I'll give you an example. A solo practitioner with one nurse and one front office staff, is not going to be able to have fully integrated on-site services of almost any kind to support that. So I just think the group should think about giving provider groups the flexibility and whatever we define as what those requirements are to provide those services in an efficient way that can be done, and whether it's virtual, whether it's through shared services, through other organizations. And I think that when we looked at other programs in the past, I would have said that most provider groups in the state can't comply almost on the surface of it. And the other point I'll make is that even if they could have the resources and the financial capabilities to do it, if the restrictions are too specific, there just aren't enough resources. For example, to put, if we wanted to have a behavioral health provider in every single primary care office, do we really have enough behavioral health providers that we physically could put those resources in place? So I think that just a word of caution as we define. I think the functionality needs to be there, but that functionality can be delivered in various ways. And we should take advantage of some of the efficiencies that smaller groups can do by working with larger organizations in ways they can actually deliver that in a way that's integrated to their care.
I think actually leads nicely, it will lead nicely to our next conversation where we talk about specific requirements for flexibilities. And so that's will come up again. We're getting close to a time when try to break. We will ask you to kind of rank your preferences after this conversation on this topic. And then we'll come back around. So any final comments before we do the initial kind of rank choice about options and where the group thinks they are in terms of option 1 through 3, and I can go back to that. Just to remind folks. Getting notes up on the screen, just what everyone's saying. And so just as a reminder, that's the option 1, 2, and 3 on kind of where we, and again, these are kind of a temperature check as to where the preferences of this group are. And these are things that again have to come back around. As Joe alluded to, it's good to have an idea of what we want, but then how do we implement it? What are the resources for these? These things will come up in future conversations as well. So maybe we'll flash up the code if that's okay. And we are back on time. Great. So for those online, you should, I think, have the email or email as well if you're having a hard time accessing the QR code. And as a reminder, this is back to what's the role primary care plays in addressing health-related social needs. Option 1, it's really not, there's no responsibility. Option 3, where they actually might. 2 is again screening, referral, maybe closing the loop, and 4 or 3, sorry, would be potentially actually addressing certain health-related social needs. And I think we're good. We'll take a break again, and we're going to come back at 11. Yep. We're going to do our final question, and then we'll do our wrap up. So we're going quickly, and thank you all again for sticking with us through some of our challenges. We're getting there. I think we're in good shape. Thank you, everybody. I think we're Michael. Thank you for. And that's
My brother-in-law's a really conversation. Actually, that's tired. Even told that Lucille Haggard. Yeah.
My favorite, I was no longer invited. And I older than I am, like, this is I joked he could have been my pediatrician from the get-go. I did so neat. Oh yeah, I can give you mine as well. Once Rhode Island got on nice to see it in person. That brought a lot of it.
It's the investment. That's what I was asking.
Yeah. But then they said.
Still been slowly.
Yeah, so if I see it in my practice.
Sources.
Whatever that's.
Like our.
That's where I.
I was just gonna say, and that's what makes life.
I'm gonna be Kept going. You know, it's like when I was like, I mean, signs don't.
I think that.
I won't really run it, right, you know? That's why they.
Yeah. Their salary, and also they don't. Different.
I
think.
Went to the national, the national. Wow. I said I was up to. I never trust. It was really nice, and I really.
I think.
You're not against.
Certainly.
Not getting this. Now, are they? That's what I want to start you.
Starting. I say, you know, if I'm on a bigger job, as a Daniel to promote it and she's overseeing all of the bid services. Yeah, I know.
Yeah. And that's what.
So it starts, it was just wellness thing.
One day, well, it's good. Okay, so then the other deciding factor is what's. And they're all like, if I could write around, yes. It's not bad, but you know, it's like, I have some.
So down here, yeah, sure.
It's a reason to win all. Good job.
Think about our goal.
Into our. I do want absolutely cute. You gotta keep things spicy. I have some. It can, I mean, I think, but I have a lot of shirts. Yes. So where the, really go in the closet and get rid of stuff. The other thing is that if there's more funding for like, yeah, I can get other. That's the. Yeah. It is like another break, going in, Rhode Island, they picked one, I think. And then. To work on. That was my other, that's another. Yeah. So I said, I have another that, unfortunately.
Yeah, the best.
What we did.
It shows, you know.
And it was the CSTEP, right? And we were the now pal, but you were already doing a lot of RFP. No, me too.
We get a lot of.
Yeah, I think that's, I think I'm maybe I should have done.
Yeah, like that.
Choice. Didn't go back to now, we're like, we're going to do all that CHA is doing, because everybody is.
friend, and one of them was trying to get that's a national, the Trinity National, and I just really wanted them to come in person, whether or not they can decide, just listening to everything, it's really good. Yeah, let me know what I can do.
Yeah, no,
Have
sure.
it sit down when the session starts, or somebody want to let me know. And get out of here. Because I feel so short. I'm like, am I really this short?
I would really love to. Have your agencies willing to be a part of it and to have them have a.
This is something that
No,
I have talked about.
And I have one, but I was thinking that and
Cover that one. Second.
honestly, I could create a platform. What do you guys
Where you're not
Bring that.
transportation
attendee?
managing other children.
So they were like, she can't come back.
Have that. I have a, you know, day-to-day life.
Yeah.
I really think. They don't want to lose me. I think the subject, you know, it came up to me. Community healthcare. You know, and it's like, I've been, like they're elderly, they actually kind of. And I did not even know what diabetes. Right, and then you gotta run it with fit issues. I had
The creativity of the next focus.
jaundice. It depends on how come feeding so well.
like stuff like this is cool.
I mean, it was nearly.
I'm not sure. It'd be interesting to.
And over 10 pounds. So he was a big baby and for me, you know, and they're like. Of having to. I would bring it on your audience.
Yeah.
But I just. Think. Yeah. It's still fine. I don't think we need to work. She said, no, you won't really do.
Action one.
And I looked at them and. I put away.
It's a really good way to focus.
Or anyway, but it's set them up. And they're like, I thought you couldn't wait until different. This is honest. For me, it's been my partner. Really.
Yeah.
I really. Everyone wants. So that's.
I agree.
Like, they don't, again, like, they don't, it's, I went one of these over this. The technology solution, and you need. Trying to figure out how to build.
No, they don't want you to want to know. But it's right. You know, and a lot of people like to count the extensions. We are to count them.
I'm here, I'm a emphasis to clearly define what that, what I can do, but thank you for provide the adequate. Everybody. You know, it was, at least to get here. I would have been every post, I come over 7, I'm like, okay, I can't do that. I'll be a few minutes late, but I'll be here. That's a Robert Jefferson's accident. If I would have left, I would have, and it's the accident, because I like to show. How, like, what are you at? So I sat there for months, heard it all, but it all worked out. Yeah. It was a beautiful.
Okay.
So I do recommend.
That's helpful.
Okay, yes.
The limitations.
My stepmom.
Those.
I'll see.
Talk about.
Slow down. Every other month. Can you slow down? Yeah. It's not the problem. Yeah.
This process.
She said there was no responsibility.
I think it's not. Very.
I missed one of the.
All right, I think we're gonna get back. It's 11, so if anyone needs any more snacks and or drinks, feel free to grab them, or bathroom. Thank you for sticking with us. I think we're in good shape technology wise at this. The screen will pop back on in a second with the slide deck, so just give us one moment. We'll hear some results.
That's a really good call. She said, we have in-person attendance? Yeah.
I think we'll be running it out of.
Right. No, thank you so much.
We cannot be, no, we cannot. That's why I didn't say anything more. Yeah.
Make it slower.
It's not my question.
Getting that up right now with some results, but just to say, our last conversation gets to kind of what Joe was talking about in terms of being scripted versus flexible with the different areas. And we're going to tailor this conversation a little bit. Specifically we're going to show you the domains that you all have actually kind of ranked in ranked choice, identify kind of the top, I think we're going to do top 4. There are 4 very close, and then have a discussion about that. So we're really going to work on those specific domains and flexibility versus prescriptive. And I'll just say, as we're getting this up, being prescriptive about certain things, sometimes these aren't necessarily mutually exclusive areas. And so when I say that, it's like, for example, in our maternity bundle, we have been fairly prescriptive about like the use of doulas as part of like the care team. I think that's something that we've said, this is really important. We're going to figure out a way to make sure where these doula services are covered. And that is kind of what I would say a relatively prescriptive part of the maternity bundle program. There's other parts that maybe are more flexible with how we've structured it. So just to say, it's not a end all be all that like you're going to be more, we have to be more flexible all the time versus more prescriptive. It's a probably yes and so we are going to use this as a domain, the domain function to talk through. So for example, data infrastructure, we may want to say, we might want to say everybody prescriptive wise plugs into the HIE. All providers have to be participating. I know a lot of providers already are connected. That may be a very prescriptive function. Because we might have general capabilities that we ask providers to have in terms of data sharing or data connectivity. So there's different ends of the spectrum, and sometimes again we might pick one versus the other, or we might have both under a same domain. So I know that can be a little confusing because we're saying, well, which one do you want? And this will be a conversation that we'll get to in just a second. Olivia, you have that up, and then maybe.
Sorry, I shared my full screen. Do we want to start with the results from the last poll?
Yeah, so we'll start with some results first. So overwhelmingly, health-related social option 2 was the one that the department that I think is not too surprising based on the presentation that occurred. I think probably not as controversial. There was obviously a few for 3 as well, which again was 3 was having primary care providers try to address certain health-related social needs in certain circumstances. And then I think the next one is the results from the first poll. Is that?
That's right. Yeah.
And so we'll see. It's actually a fair.
I guess we're
Lots of things.
Lots of.
Are we gonna get those results?
Yeah, we can send this out. But just to say, you'll see accessibility of care, very high, chronic conditions, and disease management, targeted disease management, data and infrastructure, and then HRSN screening connectivity are those top 4. But you can see team-based care is very close, number 5, and then even underneath that, overall health and creation was another one. So obviously, a wide variety of perspectives on what's important, which means we have a wide variety of perspectives in the room. It isn't necessarily a bad thing, but it also means we do at some point do need to kind of focus on what capabilities we want to target. which we'll do a little bit here. Again, as we're sharing this, actually, if people see it, just make sure. I can, yes, they can. Okay, just want to make sure folks online can see and hear. Yes. So thing I'll say is we're going to get again to this question of a little bit more information on the background and flexibility versus being prescriptive, and you'll see option 1, 2, and 3 here. Option 1 requires practices to complete specific activities or practice capability requirements that are quite in detail. You might establish minimum requirements and allow practice flexibility within certain parameters. And option 3 might be to flexibly support practice capacity and infrastructure development, enabling practices to choose what to invest in. The next slide, we kind of just provided some illustrative examples here of different ways of doing it. Some of you may be familiar with these models, some may be less. On the left-hand side, it just is the structure of care delivery environments. And then there's underneath that a care delivery accountability and overall accountability. That's on the y-axis. On the x-axis at the top, you'll see the programs and kind of the domains for option 1, 2, and 3, which they fall. Mass Health Primary Care ACO model, tiered practice capability requirements. So these are pretty structured. They have different levels. They have 3 different levels. 3 tiered Dagger has very specific requirements to be in each level, and they have different things that go along with it. But we're giving that example of a very structured one where there's specific requirements on care team integration, care coordination, and service provision. The Rhode Island Medicaid Accountable Entity Program, it's an ACO style program. It's more of a practice to find investments within allowable areas. So it gives you domains to invest in, and you can invest within those allowable areas on specific. There's 8 allowable now. And on the far right, you'll see Primary Care First, which is flexible funding practice defined uses. So the specific approaches in this one to care delivery are determined by the practice priorities. There's limited set of capabilities practice they have to attest to. So again, quite flexible in how that's approached. And so again, this is really under the care delivery. I won't walk through the rest just for time purposes. It just gives you an idea of kind of on the spectrum where you can be in terms of more prescriptive versus flexible, especially under care delivery requirements. Well, I think we can go to the next slide. And so actually we'll vote again at the end. And then this is really, again, a kind of a temperature check where folks are. Well, we'll figure out we're going to vote because I think we're going to focus on the discussion. We're going to kind of pivot a little bit and focus on these key domains that all of you kind of weighed in on and really structure the conversation around flexibility versus prescriptiveness in these areas. Again, as we kind of said before, we might be prescriptive in certain components of chronic condition management, but we may be more flexible in others in terms of what our expectations are around the care team delivery. So I'm gonna pause and try to jump us into that conversation, and maybe we'll start with care team delivery, if that sounds like a good place. And we'll try to take notes along the way, though it might be, well, maybe we should keep this up for now, and we'll paste the notes in as we go along. If that makes sense, just to keep people framework. Paul, I see. If you want to ask a question.
Yeah, and I guess I'm trying to think about, what the model has been today. We have the PCMH and the PCMH plus, right? So to participate in either of those, you would have had to invest significant time and effort as an organization to follow through and then, receive and maintain PCMH designation, which is, it's a lot, requires annual certification and gets to all these capabilities. If you've done that, there is, reward, right, in terms of certain base capabilities. So we kind of have a 3-tiered model today. However, thinking about, what would it take, on the upfront side for, kind of ensuring that we can offer, base capabilities, so to speak, and ensure that, those might be prioritized and have, less, maybe a little bit more prescriptive nature. And then for those that have more, investment in advanced capabilities or demonstrated outcomes, a different kind of level of incentive or investment.
And just to say, like, on the flexibility, there's usually outcomes that you're holding people accountable to. That's typically how it's structured. And primary care first is a kind of based off of a model where it's taking practice that already have advanced capabilities, and they're trying to hold them very accountable to specific outcomes with a little bit more flexibility. But I think the tension is like, is there a base kind of requirement that we have? And I see Josh stand up, so I'm going to get to him in just a second. But just to say, like, is there a base? What's that base? How do we measure it? How do we monitor it? But what do we think it should be? And I know this is, I think we're going to try to do top 5 choices, but maybe folks want to just weigh in broadly initially, and then we'll try to pivot to these pieces. Josh?
Yeah, and Brad, that was actually going to be my recommendation. Actually, what I wanted to sort of say relative to this is I think the conversation may be more helpful and productive if we think about it in terms of, given these types of areas, what are the areas that folks think there needs to be some more prescriptive definitions around capabilities, and which of the areas are just sort of broadly, you could see providing some flexibility in terms of how a group might be best. And I'll start that conversation with a specific item, which I'm going to guess we might be able to get some consistency around. But if you think about sort of data infrastructure and data sharing, right? There should be some standardization and consistency and very prescriptive. You need to be able to ingest this data. You need to be able to report back this data because otherwise it's not going to be functional, right? To determine how the program's running and operating, et cetera. So I think there's some components there that probably need to be very prescriptive. And then you could think of something that maybe is a little bit somewhat prescriptive, but within the HRSN component, right? You have to be able to do the screening, right? And then you have to be able to demonstrate, right, that you have the integration with the community supports and you are linking back. What does that look like? I don't know exactly, but that does feel like another area that I would at least say, right, probably relative to the discussion today, would need to be a little bit more prescriptive in making sure that folks have certain levels of capabilities. And I think we discussed that, some of the larger organizations may that may look a little different than some of the smaller organizations, but nonetheless. And then there's other areas here where just in my own experience in speaking with a variety of provider groups on a regular basis of their own capabilities and capacities, there's a lot of variation in terms of what they're good at today, of what their population need is. And so getting overly prescriptive in some of these other areas, I think is a little bit dangerous and may not result in the best outcomes as we might think about them. So just wanted to put that up.
Thanks, I appreciate it, Joe.
And what I would add to that is I would encourage us to think about the functionality we want to accomplish. Understanding that functionality can be accomplished in different ways, and should be accomplished in different ways in different organizations based upon that organization's culture, resources, skill set, and just physical setup and structure. I think it's perfectly reasonable to hold provider groups accountable to the function that we want them to do. I would encourage us to be less prescriptive about the process in which we ask them to do it. Now, I'll add on to PCMH as an example. So we chose to use PCMH as a very prescriptive, a very detailed process that's trying to accomplish a function, of which there are many other ways to accomplish that function. And in doing that, we've created a very specific choice practices had to take on this fairly significant administrative role or not. And many did, but many did not for that reason. So I think I would encourage us not to recreate that model. Also, for the main purposes, we'd like to create a barrier to entry in as many groups and as many providers as possible. And as long as we hold out the functionality that we have, I think that would be an important thing. And the final piece I'll mention again is, and I'll bring us back to this, is thinking about things that are applicable to provider groups across their entire patient populations and patient experiences, to avoid creating things that will be a single process just for our Medicaid patients. And if we could give providers the flexibility to take resources that we have in place already, which we could easily extend to the Medicaid population,
Or as we build those resources for our Medicaid patients, knowing that we could then extend them across our entire population, increases our ability to make investments in the Medicaid population initially.
Thank you, Joe. Any thoughts, responses to that?
We can all be heard now. Okay, thank you. I just also, I said this before, I just really want to make sure that when we're thinking about prescriptive and a prescriptive versus a flexible approach, that we are not inadvertently creating barriers for people who already have significant barriers to accessing care. Because if we put, I think to Tiffany's point, if we put even more restrictions on providers, then we will be limiting access in ways that are antithetical to the work that we're sitting in this room and over here trying to do. So I just say that because I know we want to hold providers accountable, but they also are operating under some pretty significant restrictions as it is in terms of resources and people and time and care. And so that's what I wanted to add. Thank you.
Just acknowledging the tension that can create, I think, between wanting to meet specific requirements, having the resources to do it, and making sure we identify what are the things that we have to do, and also not trying to exacerbate inequities for specific populations.
Well, yeah, because I use the word binary a lot. I just do, right? Because I just don't want us to create this false narrative that if we fix this, then we're going to get this specific outcome, which is our tendency, right? To think if we put all of these restrictions and prescriptions around the way that care is delivered, then we can be almost guaranteed that on the other end of that, we're going to get some really great outcome. But we know that not to be true based on our own experience. So I think we have to just be very careful about what it is that we're asking providers to do, so that we're not creating barriers that actually ask them to just, in our own way, to just step out of the process together, which then exacerbates the accessibility issue and then actually creates a worse outcome for the people that we're trying to support.
CJ, and then yeah, go ahead.
Yeah, I just want to say a little comment on that as well in terms of the barriers and data integrity, right? So while we want to maintain data integrity, we also have to be realistic, as said, about the expected outcomes and capacities. Let's be realistic with that, because some organizations do not have the capacity by size or staff. They don't get the same funding, they don't get the same access. So I hope that it is really, really considered in this conversation, right? Because if we're going to talk about improving something, let's really go in that direction, which may include making some hard but necessary changes, right? Right now, we have more folks who are going to walk-in emergency centers. That's not good, because they're not particularly dealing with anything. There's no primary care. You get sick, you just go to the walk-in. So that's where some of your data is going. So I hope that's up for consideration as well.
Definitely, I think falls in our accessibility domain for sure. Appreciate that. Joe, and anything.
Just wanted to build on what Commissioner said. As long as we are setting the goals and the functionalities we want, I think there's actually an advantage to some extent of being less prescriptive, because I don't want to say this is an absolute, but I think that the folks who are running our clinical organizations probably understand their capabilities best, they understand their groups the best, they understand their resources are. If we empower them with the flexibility and resources to work within our organization, I think that will be more effective than if we try to be prescriptive and try to advise them specifically how to do it. Again, with the caveat that the goal has to be there, the functionality we want to have or the outcome has to be there, but how the Yale New Haven Health System gets there, or Children's Medical Center gets, the CCMC gets there versus a small 3-doctor independent group gets there, may be very, very different. But I think that the end outcome can be the same.
Can I just briefly say, and the timeline might be different as well. And so that needs to be taken under consideration.
I'll lift up what Josh said a few minutes ago, and I think many people are circling too, but I think, and I'm going to say this for all of your response and consideration, I think the answer to this question really depends on what capability we're talking about. And in particular, I think we all agree we would love to pay for outcomes when we can measure them, when there's good risk adjustment, you know, when we have the data to measure, for example, on diabetes control and hypertension, you know, they're very good clinically validated measures. And in general, when we can measure and see outcomes, we should pay for them because different organizations have different capabilities. When we can't measure those outcomes, or where, you know, you can't let people decide whether they drive on the right hand side of the road or left hand side of the road, like the data standards, you know, we need to kind of mandate that. I think that the general discussion is helpful, but I also know, I think going domain by domain, I think will really help us sharpen where we're going. The only other thing I'll flag, if we land on flexible for some of these capabilities, there may be enabling capabilities that the state can give practices. And it'd be really useful to hear that. Just as an example, suppose we do focus on diabetes care, you know, with good clinical measures on that. There's also good risk analytic stratification the state can do so that every practice isn't reinventing the wheel on what's the probability that someone with uncontrolled diabetes will not get the foot exam or eye exam that she needs. You know, we could feed that to our practices and then they could do with it different, what they wanted, their different capabilities, but we're kind of having flexible, but we're hitting the foundation of the enabling capabilities. And I think that discussion is also helpful domain by domain.
Maybe one we haven't touched on as much would be chronic conditions, I think, capabilities. Is that right?
Yeah, that's at least our first result from the poll. We might start there with chronic conditions and targeted care management.
In terms of like that outcomes versus, and this may be one where we actually do have better data than in other areas, or I think as you were saying.
I mean, for consideration, I think it depends a little bit on the chronic condition, but there, hemoglobin A1C is a very good clinical measure. Primary care can influence it, and it matters for patients and their health. I would posit for your consideration. Number one would be a place where we would probably want to pay for outcomes. You want more flexibility with DSS giving enabling capabilities to providers. As for your reactions to that.
I'll just make some general comments about how I think about how our organization thinks about clinical transformation, because what we're talking about here is how do we enable clinical transformation in our delivery groups? You mentioned diabetes, pick any chronic condition. And I think that there's a continuum of how that process evolves over time. And, you know, broadly broken down into process versus outcome interventions. And we generally start early with process interventions because so you put a process in place, you can impact outcomes, and eventually all process interventions should lead to different outcomes. Sometimes we're limited by what we can measure on the outcome side. So depending on the measure, we may not, sometimes we stick with process measures because we cannot measure the outcome side well. And so my perspective on it is that there's a continuum of, it depends on the measure, it depends on the condition, depends a little bit on where the provider organizations are, it depends a little bit on where the resources have been put before. So for example, diabetes management is one that has continued down the spectrum where almost all groups are now focusing on outcomes-based measures, whereas just 3-4 years ago, we were all on process-based measures. There may be others where it's a little harder to get to outcomes-based over time. So I think there's probably, it's a mixed answer ultimately. And I think also we want to think about glide path, maybe is the right word, for organizations that have not progressed. So if there's a new organization or a new provider group that's not where they need to be for diabetes now, they can start in a process-based model and then eventually get to an outcome based on where the incentives are different for that, I think are up for discussion.
So in the conversation regarding some of these special needs areas, you reference A1C and diabetes. In high needs areas across the state, particularly urban centers, but some rural, folks are living in food insecurity in terms of lack of access to quality food at an affordable price. But also there are areas, you know, we consider those food deserts, but we also have food swamps where there are too much access to poor quality, bad food, processed food, high salt, high sugar, high fructose, you name it. What can social services, hospitals, primary care providers, you know, you write the prescription for medication, you go to the drugstore and fill it. You write the prescription for quality, fresh foods, folks are struggling to fill those prescriptions, right? And so how can all these entities, anchor institutions, be part of the solution? Because this is a very real, everyday experience. Further, retailers, they will build 5 Whole Foods in Avon and Simsbury and not one in the center where it's needed, right? Not that anyone can afford their regular prices, but how can systems use some of those dollars to offset the required profit margin to meet the needs of the folks that need access? If we keep doing the same thing, expecting different results, retailers, there's no requirement that they build a store here to meet the needs. This is a capitalist society, but that is, the status quo is killing us. We have to do something differently. How can we creatively solve for that problem? There's no easy answer, but people have to be willing to think creatively outside of the box, or we will spin our wheels and go nowhere.
Sorry, I didn't exactly raise my hand, but I want to jump on that point because that is absolutely true, right? That's what I've been saying. You got to follow it all the way through. There is no law right now that's preventing, the less privileged neighborhoods from not having all these stores that have the high price groceries. Most people are buying their basic groceries from corner stores because they don't have proper transportation, right? Or they can't get there, right? And then, as she pointed out, most of these programs, they're not promoting the healthy food. Healthy food is actually pretty damn expensive. It's actually cheaper to be unhealthy. So I think there are different ways that, there's intersection here, but there's also accountability. And the word that I hear that keeps coming up is accessibility. And I hope that is really, really considered.
I want to acknowledge that definitely lots of issues with food access and healthy food access in a lot of communities. I think we kind of talked a little bit about that. DSS may be able to have some role potentially in accessing healthy foods for certain individuals, and something that's being looked at. But for primary care, it may be difficult for primary care to solve that issue. It might be outside the scope of kind of what we're able to do here, acknowledging it's a huge issue and it is a major barrier for people to be able to improve. But there may be things that we could do, like make sure people do have access to SNAP, for example, and make that easier. That's something that is probably within the scope of something we want to think about. Is like, how do we make sure that people do have access to those benefits if they, and that is something that that could be within our world pretty easily, not easily, but like within the scope of this work. Mark?
I'm completely aligned with, I think, the challenges that Angela's raising and that CJ has amplified. Talking about all the other actors within a region and community, business, community members, community organizations, hospitals, and the extent to which there needs to be a unaligned regional strategy that will make it possible to achieve the goals of primary care, substantially more so than what I've seen nationally. I haven't seen in a dozen years of testing primary care improvement models substantial improvements in hypertension or A1C management. I think you can see some incremental gains, and primary care is a means to drive that. But early on, you distinguished Brad and Guy between SDOH, the conditions that drive the pipeline of need around food insecurity and housing, and HRSN, prescriptions or referrals for particular service solutions. That pipeline of need, the core community conditions, the structural racism that I think CJ has referred to, I do think that doesn't necessarily belong, it's not in the wheelhouse of primary care. But if we don't find a way to imagine a solution, to design a solution that can be an adjunct to primary care, I think we're missing really the best opportunity we have. And so I endorse sort of the importance of what was noted and the need for a process, if not this process, to take that on. The hospitals have been working around ways to finance those kinds of activities in communities in partnership with community organizations. And at some point, you know, not in this forum, we'd love to take that up. And Commissioner, you, I think way back, acquainted the group with EA 23-171 legislation, section 17, about this idea of root cause upstream Medicaid planning. And so that's sort of sitting out there as a to-do. I think both the state and the hospitals are interested in starting that conversation along with other stakeholders. And maybe that could be a feature of that planning process.
Yeah, I mean, I just want to say it's a huge issue and it's needed to be addressed, and primary care, I would say, like, can't fix all of these things. It's just impossible, but it does need to be an enabler, and it needs to be an intersection so that it can help. And there's things that we can do now, and there's probably other things that may be available to DSS and other state agencies in the future to help with some of these things. I don't know if you want to add anything else.
No, I don't. I just wanted to recognize Carol. I think Rand's been up for a while.
Carol, go ahead.
Yeah, about accessibility, it is about your prescriptions and stuff. So what if an individual has a copay that they can't afford to pay to pick up their medication and they need it so bad, but they can't afford the copay? What should they do? Maybe that should be in there as well for accessibility.
Definitely accessibility in a lot of different ways. Generally, there's not cost sharing with Medicaid for most things, including prescription delivery, but it doesn't mean that all pharmacies do delivery, which I think is important. So thinking about accessibility of various services broadly. What are some options? And maybe I'll turn it back to the group and say, like, as we think about accessibility, are there features that we should say are there flexible things? Are there more prescriptive things in this space? I know we haven't touched on as much. Guy, did you want to add anything else?
I actually want to lift up something, Angela, you said 2 hours ago, which was when we're thinking about the minimum requirements, we need to be thoughtful. We don't want too many requirements because that'll create access issues. But is there more that, not necessarily participate in Medicaid, but enhanced rates for practices that have 24-hour care, or just, I would love to, candidly, accessibility and team-based care are two ones where I really struggle thinking about where we should be on the spectrum between prescriptive and flexible. And I just really would love this group's thinking on those two ones, because I really struggle with those ones. Because I hear that it's annoying if there are lots of very specific requirements. On the other hand, accessibility is such an important concept, but it's also amorphous. It's hard to measure the outcome. And so that tends to make me more on the prescriptive side. So I'd love this group's thinking on this one. Angela, I didn't mean to put you on the spot. I was connecting to your comment from a couple hours ago.
I know Alice had her hand up. So Alice, maybe.
I'm sorry, Alice. I didn't realize that.
No, it's cool. I agree with what you said. I just wanted to go back just for a second, and I agree with everyone what they were saying about the first point. Yes, it's not the primary care's responsibility for dealing with these things, but ultimately it's the state of Connecticut's responsibility, correct? They have high costs in Medicaid, and it's the federal responsibility ultimately for reducing costs. That was what the ACA, the Affordable Care Act was supposed to do. So the reality is that I can spend 10 hours a week in meetings across the state, trying to address some of the very same problems. But everybody is sort of hot potatoing the problem. Whose problem is it? And I believe there isn't a structure in the state of Connecticut to actually really uniformly address it. I had put in the chat a little bit around food distribution from farms being delivered directly to homes. That's a pilot that they're doing here in New Haven. great idea. What if we were able to do it in some of the rural communities, or, you know, prescribe that and support the farmers, you know, through a mixed and blended rate. But who's going to do that? And, you know, the commissioner said earlier around IDD, and I'm bringing in autism also as an issue. They're really, you know, who's responsible for that? And, you know, it would be really important for this process to include the other really main groups that are addressing behavioral health, or, you know, social determinants of health, transportation, all of that, like have a multi-discipline group that are working on trying to problem solve. There's a lot of legislative orders right now for people to deal with things, and you know, there's not a lot of money backing it, but we've got to you know, sort of look at this as a responsibility for the state of Connecticut, and somehow use this group as a way of demanding that kind of integration of problems. Thank you.
Alice, yeah, I think, you know, these challenges do face tons of people across. I would say maybe, yeah, outside the scope of what we're able to do, though it is a huge issue. And I just want to acknowledge personally that I think, you know, we have to be thinking about solutions, acknowledging that in this scope of primary care reform, some of these things are going to be really hard to solve. They're really prescriptions for someone in a rural area. Again, we are thinking about 1115 possibilities and opportunities for certain individuals to get improved food access. And there are things that fall under this umbrella, including SNAP benefits, which may be opportunities for market improvement. Some of the other things would be very difficult, or even require additional supports or federal authority to do them for at least DSS. But acknowledging that as a state, obviously we should be caring about this broadly. Tiffany.
I've said it, I mean, we have to better integrate our funding as well as our agencies. If you see the same person in the ER, it's normally the person that has housing insecurity, normally the person that has lives in a they're normal, it's the same person. So I do agree, and to Mark's point, we have to think broader about how we're addressing the entire system. To your question, Guy, I'm wondering, can we be more prescriptive about the outcomes, less about the process and mechanisms to get there? To provide some flexibility for practices to get there the way that they need to. I'm almost thinking of it as the way that we're doing some of the data collection around race, ethnicity, and language data, where it was very clear on what the practices were expected to do. But every system is taking an approach to how they're doing it. In addition to that, using that as a case, just thinking, and we haven't decided on what we're focusing on, but once we make a decision, thinking about the supports around implementation. So even for that, you know, we are, as a foundation, bringing all the health systems together, and we are now taking the next step of bringing the small practices together to provide them education and tools on how to get there. So I just say that maybe it's more about focusing on the outcome and then providing the supports for the implementation, acknowledging where people are.
Can I ask a quick follow-up? And CJ, I recognize your hand. If you'll just
I'm not paying it.
But just one quick question. That makes total sense to me. If you, I'm not putting you on the spot, this is for the group, but if you thought about access, this is a term that keeps coming up for us. I struggle a little bit, I'm just not probably creative, to think about what is the outcome. I agree, we want to pay for outcomes, not inputs. Sometimes outcomes are easier or harder to measure. When we think about access, what's the outcome that we would want to try to measure and pay for?
So, I mean, you can look at the clinical outcomes, as we all know. I mean, that's leading us more to a pay for performance model. But in addition to that, there are process outcomes that can be measured. So whether or not practices, however they want to define it, have a way to connect people to social services, for example. And that for some practices can mean that they have a community health worker on site, or for other practices, it could mean that they have established a way to communicate with community-based organizations. I'm just using those two as examples. So there could be clinical, and then there could be, you are required to develop a mechanism for connection to social services in some way.
Yep. Thank you. Joe, I was, and then Polly, or actually, let's go to CJ first and then to CJ, sorry, go ahead, please.
No problem. So again, the word access is coming up. So we're talking about getting resources to people and possibly integrating other folks, right? So I think that when we're having these conversations, as previously noted, we should have folks who, you know, this is their main focus area, but let's keep in mind, let's not keep that group too narrow-minded either. You know, part of the problem is the lack of representation. I'll just keep saying it, because what happens is that we have the same people on different groups and nothing changes, and that's why we're here. So I hope that when we think about, you know, working with other groups and people, we also think about who should be at the table for that discussion. That's one. Number two, going back to the prescription issue, that's a big problem. That's another one that's huge. The delivery of medication that's being ignored. I get that DSS could only do so much, but also going back to the state's responsibility, you know, we have some agencies that lost their funding and resources. Some didn't even make it, and they were providing services that were actually could be useful now. Right, we had Meals for Wheels, we had all these different little things that are available in some areas now, but not others. Maybe let's take a look back at those things and see if we could get those going again, and maybe ask those agencies to say, hey, I know you were doing patient transportation before, but can we have a conversation about medication delivery? How would that look? Can we do that, right? Because we're there. You know, and I hope people really get that we are there. We can't defer anymore. We can't just give it off to this person or that person. We have to deal with it. And we also have to be cognizant of the time we're in, because if we keep having the same people at different tables, what solution are you going to really have, if not the same thing?
You want to come back?
I will. Well, I'll just address CJ's point exactly. So CJ, probably much to Guy and Brad's chagrin, I do encourage them to go out into the community as much as possible so that we can in fact hear many different voices. And I do the same thing myself. And Fatmata is here, right, who runs she manages all of our community services organizations, and she will also tell you that I reach out regularly to the member representatives so that we can have those conversations. I'm also talking to every major foundation in the state to say, who are you funding, who's doing that work, and who in your part of the state are your primary grassroots organizations that are doing the work? Who else should we be talking to that we're not talking to, whose voices should be heard? So collaboration is looking a bit different in the work that I'm doing in the time that I'm here. And I just want to make sure that that is raised up and that is heard by everyone that is in this meeting. And we will continue to do that. Okay, so thank you.
I just want to say something really quick, if I may, to that. I do want to co-sign that. It is true, DSS, you know, I could attest to having communication with folks in leadership position. I'm not going to deny that. But I also think holistically, again, I'm going to say it, and some people won't like hearing it, but I don't care. We can't give the whole onus on DSS. We have to hold the state itself accountable. You know what I mean? It's not just a one-person job, and I think DSS could do that part too of saying, hey, you over there, you have this data. Come on, let's go.
Yes, agreed.
Thanks, CJ. Joe, Polly, Mark.
Just circling back to the question about access, and I'm trying to think about how to answer your question, but then what I get stuck on is I don't think we've defined what access goals we're setting, right? And so
we have to define what we're doing.
I think that will be a recurrent theme for us as we go through any of our issues here, because I think we're speaking about generally the same thing, but I'm sure each of us has a slightly different thought of what that really should look like in our head. And then again, for those who have to operationalize that, then that goes down to another level of what that means. So I didn't mean that we should answer the question what access is, but I think
we have to define to some extent what the functionality is. And then we can come up with a model. To your point is, how can we measure it? Is it more prescriptive or more flexible? And I think then that's, we can get there. And I think for accessibility, you can get to that. I just think we have to know what it is and then we can measure it.
Thank you, that's really helpful.
So I was thinking about that a little bit too, Joe. I mean, for those individuals that we know that have a relationship with our primary care practices, you know, we typically look at things like, are we getting them in for their primary care services? When was the last time they were in? We have mechanisms not for them, you know, to hold them in. Is it a transportation barrier? Then how do we solve the transportation barrier? They can't get to us, they can't get a day off work. Do we have virtual care services? So what are the capabilities to enable, you know, those relationships really with primary care, and then looking at all those preventive measures? That's how we'll prevent them from getting up into the, you know, more complex conditions. And then I also think about things like ED utilization as that proxy measure for, are we identifying other ways from our EDs to connect people back to other services? We know who are coming often to our EDs. And, you know, are there good connectivities back to primary care providers? If we improve access in primary care, you know, and open up hours and have more flexible services, is there a case that ED utilization would level off or go down, particularly for things that, you know, are often not best treated in an ED setting? So, you know, if we think about a couple of ways from an outcome perspective, that again, might not be perfect, but are things that are measurable today, both on the side of those that we have relationships with in primary care, and, you know, I think all can agree the ED is not the best place, you know, to be receiving care.
I wanted to comment on two things. One is about the access question, and another is about the flexibility question and how to think about maybe our next meeting, because I'm assuming we're not gonna finish today. I know payment is on the next conversation. With regard to access, there's a sort of, this is not a hospital endorsed position, but what was successful when we were trying to solve for this with behavioral health in 2006 was I kind of heard sort of something along this line in your comment, was we established access standards because behavioral health access was super unreliable and there were long delays, anywhere from 3, 4, 5, 6 months back then. So we established a category of provider called Enhanced Care Clinic, and the Enhanced Care Clinic had to provide data that assured access within 2 weeks to anybody who came through the door, and 2 days for anybody who called up with an urgent condition. And there was an easy way to collect the data, feed that back and profile. So there was a dashboard up and running at the start of the program, and we saw access get to better than 90% for every Enhanced Care Clinic within 6 months' time. The Enhanced Care Clinic, and that was a broader set of expectations, but you could have an enhanced access status. So just to earn the enhanced access status and a pay differential, one could attest to or to commit to measurable timeliness around access to, if not new patients, established patients, and those are two different things in primary care. So that's just one thing I'd say is that when I think about access, how you measure it is when did I call to get an appointment and how long did it take me to get in? If it was routine versus it was sort of an urgent issue. The other way I think about it is access. One could say that Medicaid, in some way, access is manifest in the percent of adults who are not impaneled, which I've seen the number 40%. Are unimpaneled, but it depends on your attribution logic. So one of the things you could also do, if you think of this as a multi-year initiative where one of your goals is to get more people into a usual course of care and impaneled, is to reward providers based on the number of new patients they take on that helps achieve some reduced impanelment targets. So going from 60% to 62%. Somebody's taking on the new practices, and is there a part of your your performance reward at the end of the year that is a function of patients who are now newly impaneled because of their having had a visit. So that's just two ideas on the access side, but I do think making it creating a financial incentive to be creative about how you can be more efficient with your existing population and create that timeliness of access is important. On the question of next steps, one of the things I was wondering about is I totally agree with the idea that there are some foundational capabilities that should be practice-wide, like HRS and screening and referral, or depression screening and referral, that there should be every patient is on, is screened and referred. And then there are other capabilities, to your point, that could be organized around the target conditions for chronic care management. So you focus on data solutions and quality measurement solutions that are specific to diabetes and hypertension, build that really well and reliably. And so, core capabilities that need to be available to meet, basic expectations for advanced primary care for everybody. And then capabilities around the targeted conditions where the providers may have some flexibility. So team-based care may mean, for one, hiring a health coach, and team-based care may for another be having an outlying community partner with a CHW who does work in the community. But that idea of how you organize a team, maybe you have a pharmacist on, or maybe you have a co-managing subspecialist on with who's an endocrinologist, but that idea of team-based care may be an area where they have latitude to say, we spent the money to do this, and this is how we built our team, and it's how we are doing it for commercial or whatever. Similarly, around digital technologies that are enabling self-management, rather than prescribing digital capabilities, why not leave that? Look, if you can get to a better A1C outcome, just tell us how you spent the money and used it for remote monitoring or whatever. So I strongly endorse flexibility, demonstrated end of the year. This is how we spent the money in service of this targeted goal, and then also the sort of co-op.
For time purposes, CJ and then Carol, then we have to wrap up.
Thank you. I just wanted to go back to accessibility. I do not see that we put under accessibility how we define that, and more so, how do we define who community partners are? So I think under accessibility, we should really put a broader term definitions. What definitions are we using? How realistic are they? Are they really capturing what we're looking for? Because while I appreciate medical analyses, right, are we really thinking about the community as a whole, right? Are we really looking at it from that perspective and recognizing that while the community loves a good, medical, whatever word I can't pronounce right now, diagnoses, at the same time, they want to know that you care, right? Again, unfortunately for you, DSS, you take the burden of representing the state because you are most recognized. And unfortunately, you are the ones that people will come and vent to, right? Let's just say that part out loud. So I also think for everyone on the call, let's also recognize that DSS is not the only agency in the state, and that we need to do a better job of holding the other parties accountable as well, right? We need to do a way better job of that. And I think that we also need to do a better job of understanding our expected outcomes, because it seems to be very medically based and not so much community based, in my opinion. And I'm saying that because it sounds like, okay, perfectly, we want everybody to be here, but is that where they're capable of being? If that makes sense. Thank you.
Carol? Did you, anything you want to add? Carol, I can't hear you if you're trying to get off mute. You're still on mute, just FYI. Carol, you want to put your hand up? If you did, we can try to circle around with your hand, but I think Google might be providing some very summary remarks for us. And for those who haven't met the good Dr. Dalal, we're very excited to have him with us and provide his expertise to us. So Go ahead.
So for those of you who haven't met Mahmood Dalal, this is Dr. Mahmood Dalal. He is our Chief Policy Advisor here at DSS. He comes to us from, most recently from the city of New England.
Oh, I didn't.
He is
Sorry.
a doctor by training, and somehow we convinced him to come back to state service. He had originally been at the Department of Public Health, really significant work there. He also was one of the leaders through COVID in the city of New Haven, really keeping people safe there. And now he's come to DSS to lend his expertise. So we're very excited to have you. Really grateful for you. So please.
Thank you. Thanks for that.
You're welcome. Yeah.
So I was just going to try to provide some brief remarks just to kind of, I was taking notes and I know the comprehensive notes are being tracked. I'm just trying to kind of provide some brief wrap up on what we accomplished today, what we didn't accomplish today, and then where we need to go and maybe identify a few things. So I'm going to look at my notes because I have a lot here. And I don't mean this to be comprehensive. There's going to be some stuff that I missed, but I hope that's all captured. So the first part of this today, what we did is we talked about our opportunity areas: disparities, access, health-related social needs / social determinants of health, coordination and team-based care, chronic conditions, and primary care spend. Those are the 6 opportunity areas we talked about. We did a little bit of discussion there where we're in access, and we circle back to that theme at the end, that we do need to understand a definition. What is a robust definition of access? So I think that's a theme that came out throughout the discussion day around access. And in addition to the access issue, there's a related challenge which relates to the workforce. There needs to be a global solution to the workforce issue. That's something that came up earlier today. With respect to health-related social needs, social determinants of health, there was a discussion about how do we integrate behavioral health a little bit more and lift up behavioral health a little bit more in the opportunity areas. In terms of opportunity areas that we need to take a little bit more focus to potentially, identify another theme here: data. Data came up over and over again in today's conversation. That came up at the top of the discussion as well. Be mindful of the administrative burden that any of our activities will place on practices and primary care staff. We had a discussion about making sure we keep subpopulations in mind, specifically dual eligibles, those with intellectual disabilities, and making sure that what we're doing is also analyzed with that lens. There was a discussion on like, how do you really phase this? And can we set up a segmentation where we can get success at each phase so we know that we're making progress? Because there's a sequencing and segmenting issue on this long journey that we will be going on. So that was the first part of the discussion. Then we dove into primary care capabilities. We talked about 10 capabilities, which is inclusive of the health-related social needs. And some really important themes came up in that discussion. The first was, okay, when we're thinking about capabilities, are we thinking about them in terms of the ideal capability of implementation or a real, like, grounded, realistic, what can we do? And I think we kind of landed, I don't think we solved that tension, but I think we sort of landed in the middle. Like, you know, like we want to be a little idealistic, but we also don't want to be totally ungrounded in the reality. Data came up again and again. I think one of the suggestions was to make sure that we could feed back data as DSS to providers, providing rosters, claims data, so that we can inform providers' targeted outreach. Very important discussion / tension that, again, I don't think we resolved, but I think it was great to talk about and surface, was the idea around how do we approach this capability building in primary care? Do we take this approach where we say we identify the top conditions that are contributing to disparity / poor public health outcomes, hypertension and diabetes being the specific examples, but there's probably others. And then we back into the capabilities we need to address those issues, or do we talk about lifting up general capabilities across the board? Again, I don't think we landed on an area, but I think it was important to surface that discussion. Workforce again, in that discussion that came up again. Health-related social needs, I think that was where we found quite a bit of consensus, at least in terms of the options as we laid them out. There was a pretty solid majority that went for option 2. I did notice some votes for option 3, and we didn't get a chance to discuss this. I'd be very curious to know what folks were thinking in terms of option 3, which is where the primary care takes responsibility for delivering some of the services. So that might be something for future discussion, just out of curiosity, see what that vision might look like. Part of HRSN, again, dealt very much into accessibility, how do we build the linkage capability and the linkage accountability. That's a major gap right now in terms of what is a barrier to implementing some of these health related social needs and the screening, referral, closed loop system that we're aiming for. No surprise, data came up again in terms of what we talked about in health related social needs. Let me see if I didn't miss any important points there. So then we jumped into the discussion about flexibility. And again, I think we generally landed on this idea that it's going to vary based on what capability or topic we're talking about. In some cases, there might be a role for being more prescriptive, but it seemed like the general flavor was that, hey, it's better to look at the outcome and let flexibility, offer flexibility, mainly because there's so much variation between practices and the types of environments they're in. So I think there's something that we really have to consider in terms of the balance of how we address that. Another thing that came up thematically, and I think it came out a lot more in the flexibility discussion, but I think I noticed in the other parts, is that understanding and building on our existing strengths. It came up in the context of infrastructure, it came in the context of data, it came up in the context of PCMH. So I think it makes sense for us to really get a good understanding of what is going on now, what's working, and can we build on those pieces as we move forward in this journey. And then there's some other details that I think are very important that were captured in the notes. And we definitely identified the need for a perhaps separate table, or perhaps, adding to the conversation on what we're doing more globally with respect to social determinants of health. And as Mark identified, the idea that there's these drivers, the community conditions that are driving some of the poor outcomes that we're seeing that don't necessarily fall into the domain of primary care, but we definitely would be able to lend a voice to those efforts or join up with existing efforts that are addressing those issues. I think that's the end of my notes and quick summary. Is there anything major that I missed? I mean, it'll be captured anyway, but as a wrap up.
I'll just say, well, we are, so just for quick next step, because I know we're out of time and folks need to run. So just to say, we will share the poll results with everyone. We will share the notes from today. We know there's some next steps that we have, including, I think we'll take first stab at maybe trying to define accessibility as well as the other domains a bit more. And then so we can have a follow-up conversation about where do we go from here and how do we grade funding and payment with those items. So we take that back. I know, so that's on us. And I think that's really the big things for today. So it's really, we'll send out the information. We identify those priorities from all of us. You'll get information. DSS will take on the task of starting to really see if we can provide better definitions of those and figure out how we're going to braid that next conversation as we start leading to what funding do we need and then how do we pay for it. Thank you, everybody. I appreciate your time. Really appreciate it. So thank you for bearing with us.
Thanks everyone online. Appreciate it.
It went fast though.
I know.
I didn't realize it moved.
A lot of ground.
Our goals.
Yeah.
Oh,
Yeah. You sure?
Everything's a big challenge.
Yeah. Sorry about me, but yeah, there's a real thing too, so yeah, I couldn't leave him here too, but I think stop again until it's settled.
Oh, yeah, right? Yeah, absolutely.
Legislature.
I think what some of them were saying on the.
I don't understand it. I can't. I don't understand. I was like. Right, remember, I can see. You can see what. I think if anything. Thank you. I don't know. We can do it.
I had school. Either one.
Thank you. Yeah. Let's connect. You, I don't know how that. I'd rather just take my job.
Yeah, it's like reality. Yeah, I mean, I think still.
Yeah.
Do a decision, you know.
You did make it.
I mean, we're sitting on. You know.
Yeah.
they know.
She said it. She said it.
The other option.
State's friend.
Well, the other option would be therapy. Yeah.
Clean up.
As well, take care. We'll be chatting, I saw. I'm sure.
We have about 1,300 buyers.
Nice to see you and thank you so much.
Fairfield, look at the county.
Yes, yes. Nice to meet you.
Our groups is independent. Yep, that's our. I agree.
Yeah.
And I hope it will also. Future meetings, now we.
Yeah. But it might be beneficial in another critical
I agree.
juncture.
Yeah.
I'll give it come back up. Thank you.
All right.
I personally- You're gonna-
All right.
Still-
You guys are.
Thanks very much. Thank you for having us up. It was really great being in person.
Yeah, it was so nice.
Thank you.
Yeah, that's so great. Thanks.
Thanks for your